without any changing DNA. Then we also learnt about genetic alterations that lead to disease, such as mutations, inborn errors of metabolism, and all we had discussed. Then clinical relevance, and coming to clinical relevance and future advances, ma'am has emphasized about CRISP, which is the recent thing, gene editing, which that also we had learnt about that. Okay. Then next session was held by Dr. Muthuselvi, APT ma'am. She has discussed about physiology of growth. In that, those highlights were that we learnt about the core concept of growth, which is hyperplasia, hypertrophy, and accreditation. Then also we learnt about master axis for growth hormone is one is growth hormone, and then insulin growth factor, which is a principal regulator. This growth hormone will stimulate liver, then insulin growth factor, which lead to linear bone growth. Then the regulatory shift for growth hormone also ma'am has discussed. One is for fetal growth, insulin and IGF-2, which is growth hormone independent, and for postnatal growth, growth hormone and insulin growth factor, which is dependent. Those are the things which were highlighted by ma'am. Also other hormones which play a role, such as thyroid hormone, insulin, and sex steroids. Then ma'am has discussed about clinical correlation in growth hormone, that is causes for decreased growth hormone and increased growth hormone. Then growth hormone resistance, that is Lawrence syndrome, whereas decreased thyroid hormone also, which lead to cretinism. These are the things which were discussed about ma'am yesterday. Then the next session, was taught by Dr. Janith. He had discussed about hemodynamics. In that hemodynamics, he had emphasized about that flow of blood and the governing forces, that is pressure, flow resistance, and velocity and all. Sir had discussed. Then pressure profiles and all were discussed for aorta, arterioles, and capillaries. Those things we had, sir had discussed. Then loss of blood flow had been discussed, that is Poiseuille's law. Then laminar versus turbulent blood flow, also viscosities, which depends mainly on hematocrit, were discussed yesterday. Then coming to arterial hemodynamics, sir has discussed about blood pressure basics, then compliance and pulse wave velocity and all discussed. In compliance, Wien-Kessel effect, that is the important thing which for sir had told for PG students. Then micro and venous circulation, sir had discussed about stalling forces and venous return forces and all. Then coming to applied thing, about auto regulation, that is both myogenic and metabolic regulations, which were seen in brain, kidney, and heart. Those things were discussed by sir. Then disease relevance also were discussed. Then last thing is recent advances in hemodynamics. Sir had discussed about endothelial factors and central aortic pressure and all. Then about glycocalyx, that is reverse stalling principle. Those things were being held yesterday actually. Hope we had an insightful discussion yesterday. Thank you.
Good morning everyone. Yesterday class ma'am discussed, and other than the second part of the discussion of the yesterday topic is cardiovascular system of reasoning out. Dr. Mugil ma'am explained about the reasoning out. This reasoning out about the role of beta blockers in tachycardia due to his acts on the SA node and the AV node, and also she taught about low pressure gradient in pulmonary circulations and protectives. These are due to pulmonary stenosis, and also sports goals with murmur due to left ventricular hypertrophy and hypertrophic cardiomyopathy, and also orthopnea in left heart failure. And next reasoning out also hypertension with concentric left ventricular hypertrophy and dyspnea. These are all the topics covered, and also coronary flow maximum in diastolic pressures, and also in pulmonary capillaries. And also ma'am thought about the Wien-Kessel effect in this reasoning out of the cardiovascular system, and explained about the why pulmonary pressure is low in the Wien-Kessel effects, and also arterial kick in mitral stenosis, and also AV nodal delay and dilated heart works, and also more and more peripheral edema in cardiac failure and dilated cardiomyopathies, and thin wall capillaries and resist of rupture due to cardiovascular system defects, and also ACE inhibitors are contraindicated in renal artery stenosis. And Louis Benita madam, doctor, also talked about acid base balance and pH of levels of acids and bases, and also buffer systems she taught it, and respiratory and renal regulations and disorders of acid base balance and due to metabolic acidosis and metabolic alkalosis and respiratory acidosis and respiratory alkalosis. These are all done taught about, and values she taught, how's the metabolic acidosis happen and all she taught it. And also applied aspects and recent advance. And Dr. Senthil sir also taught about the nutrition values. It's protein, carbohydrates and fats, vitamins and minerals, and energy metabolism and nutritional assessments. And also applied aspects of the recent advance in the nutritional values. He also in recent advances he taught about precious of nutrition and nutriogenomics, and also gut microbes and diet interactions, and also he thought about gut brain axis to control the brain by stomach while food is empty, and also chrononutrients and time restricted eatings, and diet cellular aging and longevity, and diet immunity and brain axis, and also omics and integrations of AI nutritions. These are the recent advanced thought about the nutritions and its values. Thank you.
Thank you, Dr. Bharati ma'am and Dr. Prabhakar sir, for this concise and brilliant synthesis of what happened yesterday. Before we move on to any further events, I would like to take up a moment to acknowledge one person, Dr. Jami Patricia. You are a fellow postgraduate who is from PSG Medical College. She topped yesterday's post-test. So please give her a big round of applause. Wonderful, Jami. Congratulations and best wishes. And don't worry, you'll be felicitated with a small token of our appreciation. I'll wait for a few more minutes so that all the delegates, let them be here so that your knowledge gets duly appreciated. And thank you very much. Thank you. Good. So guys, I think it's time to move on to the very first session. So let's begin with a brilliant talk from our very respected, very senior professor, Dr. Sethupathi sir. In order to have the session, I would like to call upon our beloved chairperson for this session, Dr. Inmoli ma'am. I would like to ask the chairperson to invite and introduce our beloved speaker for the first session. Over to you, ma'am.
Sir, don't mind, can I sit here? Good morning, one and all present over here. Thank you very much for me giving this opportunity. Before that, I should thank my dear close friend Sudha. She's the one and all doing all this. We are not separated. Biochemistry and physiology always close to each other. Past 35 years, I was here as the professor of biochemistry with the guidance of Dr. Sethupathi. Without him, I'm not here. He is one of the best teacher and my guide. I'm very proudly say I'm his student, first PhD students. After that, I have retired. Now I gone to Nanda Medical College, E-Road. Very proudly say that he is the man of action behind us. Thank you very much, sir. Kindly present your topic. Thank you.
So though I belong to physiology department, I will be mostly in the biochemistry department only because I did PhD. But they were more friendly, though they are seniors. They accepted my invitation. Both are retired professors. But I am very much happy and I am very proud to say that they have acknowledged to come here and present and for chairperson. So only I selected Inmoli ma'am for a chairperson for Sethupathi sir. Thank you, sir. Thank you, ma'am.
அனைவருக்கும் வணக்கம், வாழ்க வளமுடன். I'm very happy to be here. I thank Dr. Sudha for inviting me for this lecture. Okay, and Dr. Inmoli was my colleague for the past 30 years. Actually, we worked here for the past 30 years in Annamalai University. We all belong to RMMC family. Okay, so we are all close family friends. Dr. Shanti is there, so many of us are there. Okay, right. The moment topic was given to me, I was worried. What energy, integration, metabolism? I think most of you will run away. Biochemistry, pure biochemistry, take no finished. Okay, nobody will listen. So what I've divided into my topics into 3 parts. One is a brief summary of the biochemistry of this, then some hormonal regulation, some practical applications for your day-to-day life. Because diabetic is a metabolic disorder, and most of us are diabetic only. Okay, so I just want to make it more useful than more scientific. Okay, almost our aim is scientific to be applied for the benefit of this human society. Okay, so that's the reason. Okay, now let me go to energy. Still we cannot define. We just say a system to, it comes out an output like moving an object or change or do some work, something like that. Okay, and the energy can be in different forms, like you have a mechanical energy. For example, body, muscle contraction is a mechanical energy, light and sound, and electrical, nuclear, thermal, magnetic, and chemical energy. These are the various forms of energy. Our body has got uses chemical energy, okay, but it converts to mechanical energy, and your audio signals is converted to electrical energy, like this. Okay, so that is why we have ATP. All of you know ATP is energy currency of the cell. So that's chemical energy. Of course, all of us metabolism is the base of life. That's okay. But anabolism, you synthesis of the compounds using energy, and catabolism is the basic. Okay, they give energy for synthesis. Remember, both anabolic reactions, catabolic reactions go together simultaneously. But if you always eat separately, these anabolism, catabolism, but it always go to the simultaneously. Like you have, you can't have positive charges and negative charges isolated. Always there will be positive and negative together only. Okay, that's why. As you know, this ATP is produced by the catabolic reactions. Okay, catabolism is nothing but bigger molecules are broken into smaller molecules. For example, glucose is converted to carbon dioxide and water. Okay, during this process we give energy. For all of us, the energy is from sunlight, solar. So solar light is stored by the plants by photosynthesis. They synthesize starch. The starch we consume, they become glucose and metabolize to give energy. Okay, so ultimately, no sunlight, no life. That's why our ancestors, they always first they pray sun. Okay, sun god. Okay, that's the thing. And like electricity, you cannot store. We can store a small amount like batteries, UPS. That will last for a few hours. But complete energy cannot be stored. Okay, like that ATP cannot be stored. Immediately it should be used. Okay, but in one form it is stored, that is creatine phosphate. Creatine phosphate in 3 places, very important places. Brain, you have creatine phosphate is there, because brain function is very, very vital. So like UPS is already, it's required for brain. Okay, and muscles also require, and cardiac muscle also requires creatine phosphate. Okay, that's why creatine kinase and enzyme. We create creatine kinase MB is an isoenzyme used for the diagnosis of myocardial infarction. Okay, so there are 3 isoenzymes. One is CKBB, that's brain, and CKMB in heart, and CKMM in muscle. So these are the 3 places where you can store energy. Okay, the form of creatine phosphate. Right, these are the various forms of energy in our body. Like you have ATP, glucose, fatty acids, amino acids, all they give rise to chemical energy. Then electrical energy, nerve signals, electrical energy. Then you have thermal energy, body temperature maintained, that gives thermal energy. Then potential is the storage form of energy, that is like a battery stores electricity. Like this, glycogen is a storage form of chemical energy, that's split into glucose and further gives the energy. Okay, so that's the thing. Some of the natural examples, this electric eel found in South America, see, that can produce 600 800 volts only. That is from chemical only, from chemical energy converted to electrical energy, 500 to 600 800 volts. Use electricity is because when it passes electricity, the prey gets stunned, so they get fainted, so automatically they can swallow. That's the reason. Then they also use electricity for having a map. Okay, so suppose it travels in a path, it can send the electrical energy and see the obstacles, then it diverts like this. Okay, brain mapping also can do this. So sometimes I feel, no, most of the youngsters, no, they have a problem with the cell phone recharging. So charging the phone, electricity, they find the plugs, charger. After some time, whenever you eat something, you put the cell phone also with the enzymes. It convert the chemical energy into electrical energy and charge the phone. That will be possible soon. Okay. And bats, they use ultrasound. Based on that, ultrasonogram you have actually. It sends the ultrasounds and echoes. It analyzes echoes and see. Then your firefly gives light. Night, you see the lights. Firefly. Okay. So why I'm saying this is chemical energy can be converted in any form. Okay. So that is why everything can be made possible in future. Okay. Then luciferin is a thing that gives light. Using this principle of this luciferase enzyme, we have a method, chemiluminescence immunoassay method. We are using this in the biochemistry laboratory. It's very accurate method for analysis of hormones, everything. Okay. So chemiluminescence immunoassay. Then body temperature, thermal energy. Okay. So these are the various forms of energy. Okay. Mitochondria, little basic, biochemistry, just see. Breakdown of glucose, that's a process called glycolysis, breakdown of glucose, and pyruvate is formed. Pyruvate is converted to acetyl-CoA, which enters citric acid cycle. All of you know citric acid is very famous, all cycle. Okay, so this, the fatty acids get oxidized in the mitochondria. Okay, the mitochondria. There's one importance there. Citric acid cycle path, common matter. It's a common metabolic pathway because some of the compounds of the citric acid cycle intermediates, they can be converted to some useful compounds, and this also gives energy. That's why it's called as common metabolic pathway. It's both catabolic and anabolic. Okay. This small calculation, don't worry about this. It yields 1 acetyl-CoA molecule give 10 ATP. That is 3 NADH, 1 FAD, 7.5. 1.5. Then at the cell, cycle itself have 1 ATP there. So total you have 10 ATP. So this is thing. How this energy is electrical energy is converted to ATP. That's the thing. Mitochondria. Electron transport chain. It transports electrons. Okay. I'll see this. See, this is electron transport chain. Okay, all right, okay. So there are complex 1, 2, 3, 4. And the last one is cytochrome oxidase. So what electron transport chain is, it pumps protons to intermembrane space, outer membrane, in between the space is there. Okay, there it pumps, and the protons are there. The protons, they pass through ATP synthase. Where ADP is converted to ATP. This is the basic thing of the electron transport chain. Okay, so electron transport chain is nothing but a proton pump, and the electrons are flowing through this. Electrons plus protons plus oxygen forms water. So these three things are forming water, and ATP is formed. Okay. So this is the free energy. Slowly it gets reduced. Okay, no problem. There are two types of respiration. All of you know this: alveolar respiration and cellular respiration. Cellular respiration is mediated by mitochondria. It requires oxygen. Okay. Here oxygen is converted, used for the energy production. Okay. And the cytochrome oxidase inhibitors. So some practical thing I want to say, you have this cytochrome oxidase inhibitors, hydrogen sulfide and cyanide, carbon monoxide, sodium acid. Two important things every day we see in our life is carbon monoxide poisoning, automobile fuel. Okay, so that's very, very important one. Second one is you have hydrogen sulfide. The people who clean the sewage canals, all this, it's full of hydrogen sulfide. Okay, so these are the two important things we come across every day. because if you keep the generator outside, it may get stolen. Okay, so what they thought, they just kept inside the house and they were sleeping, and the father and mother slept off finally, and children somehow they escaped because they have physiological resources more in children, so that's why they escaped. Another thing in Chennai, same thing, that one fellow went to a bank, everyone is sleeping, bank, money handling area, how he was sleeping. Okay, so they immediately called. What they did, they operate the generator inside the closed room. Okay, so remember this, whenever you operate the generator, it should be away from the thing. You should not keep it in the room itself. Okay, so it should be away, it should be well ventilated area. Okay, so that's one important thing is there. Okay, carbon monoxide, that's the thing we are just okay. Next is hydrogen sulfide. When you want to rescue, suppose somebody fallen in the well, full of hydrogen sulfide may be there, so what you want to rescue, you have to be very careful, otherwise you will also succumb to that. Okay, so that is why. And for this, why carbon monoxide causes death is carbon monoxide has high affinity for oxygen, 200 times more oxygen. Okay, it does not allow the oxygen to get delivered. Okay, so it has more affinity for the hemoglobin. So you have to have a 100% O2 therapy or hyperbaric oxygen therapy to save the patient. Okay, so immediately give a lot of oxygen. That's the thing. H2S, you have this antidote is nitrate. If you give nitrate converts hemoglobin to methemoglobin. This methemoglobin combines with the hydrogen sulfide, and so you remove the hydrogen sulfide so that you are safe. Okay, so at the same time you have to give oxygen also there. Right, coenzyme Q also now commonly used in clinical practice. So coenzyme Q is, when you see cholesterol synthesis, you have one enzyme called HMG reductase that is inhibited by your statin drugs. Statin, all this. Okay. So what happens when you give the statin drugs? You give the night because the night. Okay. So the patient may complain of leg pain because of the taking the drugs. Okay. So leg pain because the reason is when you obstruct the, you block the pathway, a byproduct is coenzyme Q. So that is also not synthesized. So that's an antioxidant, and then coenzyme Q is the mitochondria. That's the transport chain. So mitochondria is not working properly, so no energy is circulating, muscle have a muscle aches. Okay. So that's the reason. Then that is why you will failure because you boost the mitochondrial function by forming more of transport chain coenzyme Q. Then some of the neurotransmitter disorders. Okay. Parkinson's disease, they act as an antioxidant. Most of the things now everything they do antioxidant coenzyme. Okay. Then uncouplers. Uncouplers, I told you transport chain. When the protons enter through the ATP synthase, only give ATP. Suppose if it enters some other route, no energy is produced, but oxidation is occurring. Okay. So oxidation occurs, but no phosphorylation, no ATP is formed. So that's why hand over rice. I still remember. But certain things you see, another important thing is, anything you want to make into habit, you just continuously without break follow for 45 days too. Okay, that's scientifically proved. If you can follow anything for 45 days without break, it becomes your habit. Then you enjoy that actually. After that you enjoy. This 45 days is very difficult. Suppose you want to start, that day only the friend will come. They will have biryani today. Finished. So a lot of obstacles will come in the beginning. Later on only you have to. So if you bypass all these obstacles in the 45 days, you can develop a habit. Okay. So another important thing is, when you want to control diabetes, suppose you want to develop a habit, don't take too many things. Slow walking, at least you have one salad which 45 days follow, then go for next thing. So add this. Okay. So you can go and add one or two things, one thing as 45 days. So in 1 year, you develop all good habits of the thing. Okay. Right. Now, how this principle can be used for diabetes management with the insulin? Suppose nowadays our people are mostly the carbohydrate, morning idli, after rice, all this thing. Okay, they have a right. Carbohydrates have a spike is more. They make spikes. Okay. So what you have to do is, you have to give more of high bolus insulin, that's immediately acting. Okay, and basal insulin should be less. Suppose I take a large amount of proteins, then I should go for more basal and less bolus, because spikes I don't have, but I have to maintain the glucose level, so I will go for basal is more. Okay, these are the two principles of the insulin treatment. Okay, these are things are given. Okay, right. No, latest is you have a glucose receptor antagonist they have. Okay, glucagon receptor antagonist. Okay, it has come, but it's not completely come into the market, but it's a brand. It has come actually. They are using one injection costs about 3,000 rupees. Okay, once in a week. So what happens here? Glucagon increases gluconeogenesis. Okay, so when the receptor is blocked, the glucose release will be blocked. Okay, automatically the glucose will drop down. Okay, one more thing I had actually. Sodium dependent glucose transporters 2 inhibitors are there. They used. Okay, that is in the kidney. The function is it increases the excretion of glucose in the urine and bringing down the glucose. But the problem is, I know one of the patients, he developed sudden weight loss. Suddenly, நல்லா faster கொஞ்சம் என்னன்னு கேட்டேன். Then she told me this tablet I was taking. So I told, see, you are excreting glucose. Okay, that's not the solution actually. You are increasing the problem. How? When excess solutions, the other systems work, they produce glucose by gluconeogenesis from muscle amino acids. Okay, so when you excrete more glucose, you go for more gluconeogenesis, because your system will try to maintain the glucose level at a higher level only. So automatically what will happen? You lose loss of muscle mass. Okay, that's the thing. So if that is not used, okay, isolating it. Okay, you should be very careful using this. Okay. Okay, this side liver toxicity, because it acts at the liver, automatically you have liver toxicity, then you have rarely hyperglycemia is there. Normally how fasting is managed? 0 to 6 hours of food, insulin little reduced, glucagon little increased. 6 hours, after 6 hours, slowly glucagon increasing. Okay. Then this glycogen can manage for 6 to 24 hours. Depends on the activity. Suppose if you are actively involved, glycogen store will be last faster. If you are slow or not active, it will be last longer, 24 hours. Okay. Then depends on the activity also. Intermittent fasting is 1 to 3 days. Suppose 1 to 3 days you go for fasting, or it's an intermittent fasting. Brain RBCs need glucose, because brain has not adapted to ketone bodies utilization. So automatically both of them are require glucose. Okay. So what will happen now? Glucose increases. Then lipolysis, adipose tissue lipolysis, they release fatty acids. Okay. Then slowly the ketone bodies will be started producing. Okay. That's fatty acids reach liver, ketone rods. Okay. So these are the things. Prolonged fasting, more than 3 days. Brain starts using ketone bodies. After 3 days, slowly brain can start using ketone bodies. So the requirement for glucose is less. So automatically gluconeogenesis will be lesser. Okay. Then okay, how long we can survive fasting? Without water, only 3 to 5 days. With water, it has reported 61 days. Fasting strike, that's one fellow was 61 days. Okay. How we manage for fasting so long? Because adipose tissue, triglycerides stored. See, it has got a lot of energy. It has give a lot of energy. Depending on the lipoprotein triglyceride storage, you can live longer or lesser. If you have a thin, less triglyceride means you cannot live longer. More means you can live longer. How it is there? Okay, I'll tell this. Okay. So this graph shows. See, this is the immediate, first graph down. Okay. 6 to 24 hours glycogenolysis, breakdown of the glycogen into glucose. That's the first process, maintains up to 24 hours. And the meantime, slowly lipolysis increases in ketone bodies. Okay, so after 24 hours, it starts increasing. And this part only I want to say, give emphasis. Second, no peak is there. Peak then down. That is 1 to 3 days, you have more gluconeogenesis. Okay. Once the brain starts using ketone bodies, that is not required. So automatically what will happen? It drops down. So the second phase, you'll have loss of muscle mass. Then after that, body needs to protect the muscles. Okay. So automatically it will cut down the gluconeogenesis, and brain uses ketone bodies for energy. So automatically that will come down. That's the thing I just want to emphasize. Okay. Okay, imagine how long fat store can increase survival in fasting state. Simple. So suppose normal 70 kg person has got a normal BMI, no obese. Okay, he can store up. His store is 10 to 15 kilograms of fat. 10 to 15 kilograms of fat. Okay, so 10 kilograms, it comes around 10,000 grams. Each gram gives 9 kilocalories. So 90,000 kilocalories you have. Okay. So per day you require only 2,000 kilocalories. Automatically you can live for 45 days. Okay, so easily you can live. Okay, so the adipose tissue store is maintain your life during fasting. That's the thing. Okay, so how much water you should take during fasting, prolonged fasting? Should have a normal, because dehydration is very important. Second one is you have a, toxic waste should be removed by the kidney. So 2 reasons. Okay. Okay, how death happens in fasting state and diabetic state? They are different actually. Fasting state is physiological ketosis and is limited. See, a ketone is not excessively produced, just requirement alone is produced. Okay, that's the thing. Then second one is due to prolonged gluconeogenesis. But the problem with death here is there will be prolonged gluconeogenesis. Okay, automatically the muscle mass will be lost. Usually first non-vital tissues, muscles only get lost, but later on it will involve vital muscles also, like heart, diaphragm. So ultimately the muscle mass of the diaphragm, heart will lead to death of the subject. Okay, prolonged fasting. Okay, so cardiac failure, respiratory failure. In diabetes, death occurs 1 to 2 days because excessive. There are two things. Dehydration is very, very important because glucose exceeds in the urine, electrolytes, ketone bodies exceed in the urine, so it takes away a lot of water. That's called osmotic diuresis. So it takes away a lot of water in the urine, automatically go for dehydration. Second one is electrolyte imbalance. Potassium. Okay, hyperkalemia is very, very important. Okay, so these are the things. Okay. Okay, now the problem most of us say insulin resistance. How you can prevent insulin resistance? That must be our question. Okay, if you don't develop, you have not developed it. One is excess calories. You have obesity, high abdominal fat, everything is there. That's one. Second one is high level of free fatty acids. You have high level of free fatty acids. Okay. Then third is fatty acids mainly taken up by the liver and muscle. They are mainly taken up by the liver and muscle. When the muscle takes the fatty acids, it doesn't want glucose because already fatty acids are available for energy. Okay. So automatically requires, it takes up fatty acid does not take up glucose much. What happens? The glucose level goes up. When the glucose level goes up, automatically insulin level increases. So glucose level goes up, insulin level increases, so it goes on. The vicious cycle sets in. So there will be starting hyperinsulinemia will be there. So you have to cut at the beginning itself. Our ancestors, they used to have fasting, அமாவாசைக்கு fasting இருப்பாங்க, ஏதோ இருப்பாங்க, fasting இருப்பாங்க, எல்லாரும் தெரியும். நம்மளாம் fasting என்னன்னு தெரியல இப்போ. That's the truth actually. ஒரு வேளை சாப்பிடலாம், ஆனால் பயங்கர பசி உயிரை போகிற மாதிரி இருக்கும். Okay, so fasting எப்படி improve ஆகுது? What is this? It improves insulin sensitivity. Okay, yes. How? Beta cell rest. Everything requires rest. We require rest for muscles, requires rest for brain, requires for heart. எல்லாத்துக்கும் ரெஸ்ட் வேணும். After that they get recharged and they work better after that. Okay, so that's the thing. So beta cells also continuously go on secrete insulin. Ultimately it's also getting tired. Okay, it has to have a rest. Second one is insulin sensitive by tissues. So the idea is when the tissues are in fasting, they'll be longing for the glucose. So once food comes, they actively take up. That means they just get recharged. Okay, they active better. That's sensitivity will be increased. That's normal only. Okay, suppose you are fasting, suddenly you get some rice, you will enjoy it like biryani. Okay, so like this, it gets recharged and does. Okay. It increase lipolysis, reduce abdominal fat. So automatically reduce the lipolysis. So automatically go fat is there. But the most important thing is we should avoid overeating. Fasting alone will not help. You have to avoid overeating. Okay. Right. Amino acids metabolism in fasting. So what happens to amino acids? During fasting, muscle use mainly branched chain amino acids because liver cannot use branched chain amino acids. So muscle can use branched chain amino acids, and the products they release alanine and glutamine. They are used for gluconeogenesis, synthesis of glucose by the liver. Then glutamine is used for renal acid secretion. The acid base they would have covered. Okay, glutamine is used. Glutamine is enzyme release ammonium chloride. So that goes on like this. Then brain does not oxidize amino acids because of ammonia toxicity. Because the product of amino acid oxidation is ammonia. So brain doesn't want to have ammonia toxicity. Because all of us know ammonia toxicity is very dangerous for the brain. So that is called hepatic coma is due to ammonia toxicity. Okay. And leucine and lysine ketogenic not used by liver. They are ketogenic, so not used by the liver. Right. So what is the important role? Diabetic diet. You have prevent spikes, maintain glucose level, and maintain body weight. So one suggestion is fiber off plate. Very, very difficult, impossible sometimes. Then you have a quarter plate protein. That's okay, you can have chicken something. That's also oil should not be there. Okay. Actually my daughter wanted to reduce her weight, so she's using air fried. One day she gave me air fried chicken. It was tasting good only, not like so without oil she prepared. So air fried also good. Suppose you want to be actually involved in the weight reduction, something like that, you can use air fried. Okay. And carbohydrate quarter plate. Okay. Then you have low glycemic foods. Avoid white rice, fats, and sugars. Right. How protein prevents spikes? Suppose you take large amount of protein. Okay. Protein rich diet. Okay. It's always prevents spikes. The reason is their slow emptying and increases glucagon like peptide 1, and it increases insulin secretion, replace carbohydrate. And two things, leucine and arginine, amino acids, they directly stimulate insulin secretion, leucine and arginine. Okay. This graph actually, I like this graph actually. In the first peak, if you take simple carbohydrates, that forms a big peak. Second is complex carbohydrates like vegetables, salad with this. Okay, so not simple carbohydrates. Sweets, simple carbohydrates. Sugar, sweets, simple carbohydrate. Okay, so when you take complex carbohydrates, small peak. When you take protein, still less. When you take fat, still less. Okay, so now you know the importance of the how peaks are produced by the various diets. Right. நிறைய பேர் கூழ் குடிச்சா நல்லா இருக்கும்பாங்க. ஓகேவா, டைலூட்டாக சாதம் கரைச்சி குடித்தா நல்லா இருக்குப்பாங்க. அது வந்து because the reason is when you take solid meal, see how the comes, blood glucose level slowly drops down because slow emptying. When you take liquid diet, see how fast it comes. Okay, rapid emptying, so you'll have a spikes will be there. Okay, and you have a glucagon like peptide 1 has got 3 actions. One is increase insulin secretion. Second one is gastric emptying is slowed, GI motility is reduced. Third one is it reduces appetite also, so you don't have much appetite. Okay. Then one of my classmates' daughter, she came to my house. She was having idli, 2 idlis for half an hour. I was telling, what are you doing? That reduces weight because they slowly eating. So no insulin, insulin will be less. Automatically you take little and you are all right. So no weight. Okay. So that's why when you eat slowly, it's better. But nowadays it's not practically possible. Morning, go to the job, automatically at least one time you can try. Evening time, night time, free half an hour, 1 hour சாப்பிடலாம். அதாவது பண்ணணும். இதெல்லாம் நம்ம ஹெல்த்துக்கு தான். ஓகேவா, வாட் எவர் யூ ஏர்ன் that's immaterial unless your health is protected and it's not important. Okay, so you have at least one meal, slow eating. Okay, Afternoon also difficult. Somewhere here, somewhere there. Okay, no problem. Okay. So ultimately, night is okay. Most of us say night is okay. And early diet is better because when you go to bed, no, you should have empty stomach. Okay. Most of us feel empty stomach. மறுபடியும் பசிக்குமே நைட்டு மாடிச்சா என்ன பண்ணுறது, ஆனால் பிஸ்கெட் திங்கலாம், அப்படி இருக்கக்கூடாது. பழகிடும். It will get used to it, adopted. Thoughts, no, the thoughts is like this. This slide is very, very important for me. This is also a very important slide I just want to see. When you take carbohydrates first, நான் சாப்பிடும் ஃபஸ்ட்டு கார்போஹைட்ரேட் சாப்பிட்றோன்னு வச்சுங்க, என்ன ஆகும் பாருங்கள், பீக்கு அப்படியே போயிடுது குளுக்கோஸ் லெவல்ஸ். When you take proteins first, okay, carbs last, that is carbohydrate. Okay, I told you, no, on order: fiber, protein, carbohydrates. Okay, when you take last carbohydrates, see how slowly glucose level increases. So no peak is there. So that's importance of taking carbohydrate the last, before fiber and protein. I mean, not before this. Okay. You may say, what is the incretin effect? That is GLP-1. What is the effect? This is the glucose level, but the incretin effect, see insulin. There is insulin response. Okay. So this is the thing. So when you slowly eat, incretin is more. That is GLP-1 is more. Automatically insulin level, there is no peak. But when incretin effect is not there, see almost similar to glucose level. That's the thing. See, in diabetes, see the incretin is a bit less. Okay, it is less. Where normal it is more. Okay, so that's one reason. Okay. Epinephrine. A few slides I'll finish. Time and time up. No, 5 minutes mudichira. Because time is very important. No? That's otherwise you will get disturbed. Okay. Epinephrine increases glycogenolysis, all these things. Okay, cortisol increases glucose. All these things increase the blood cell level. Okay, that's hyperglycemic hormones and growth hormone. Its action. Okay, all of you know physiology. They know actually. Then stress. This is the last 1 or 2 slides. Stress and eating. Most of us, you will find pleasure when you are under stress. See, we feel some relief. Okay, so that's the important thing to put on weight. Stress increase cortisol, lipolysis increases lipolysis, fatty acids, insulin resistance. Finished. Then you have accumulation visceral fat, central obesity. Okay. Sleep deprivation. That's there. That's low grade inflammation, sympathetic activity, all this is cortisol, insulin secretion. Okay. So ultimately you have sleep is very, very important. Okay. So this is the pathway. We have a hypothalamus, we have a CRP is increased, ACT is increased, cortisol is increased, then glucose is increased in the liver, hyperglycemic insulin resistance. Okay. Another thing, diabetes infection is very, very important because controlling infection diabetes is very, very important because a vicious cycle is there. You will see infection, you have this increased production of stress hormones, increased production of cytokines, infection of the beta cells. So there will be infection itself produce hyperglycemia. Diabetes, you have hyperglycemia and that produces immune suppression. Okay. So diabetes, immune suppression, more infection. Infection increases diabetes. So it's a vicious cycle. So you have to cut down both. How will you cut down? So infection, increase glucose, decrease immunity, increase infections. Okay. So both are also there. Okay. So that's a vicious cycle sets in case of diabetes. So you have to be very careful in controlling infections and diabetes. Usually during diabetes, no, even on the oral anti-glycemic drugs, no, hyperglycemic drugs, no, you can give insulin, then go for, once infection is controlled, go for oral hyperglycemic drugs. Non-alcoholic fatty liver disease, you have Now we'll see every girl, if we see, all the people you see ultrasound, grade 1 fatty liver disease. Everyone says, okay. So that's the thing, important thing. Okay. The reason is you have diabetes mellitus, hyperglycemia, sedentary lifestyle, all this is okay. The most important thing, sweets and sugars is very, very important. Sugars does not give much calories, but it has a lot of other effects. It gives only 4 kilocalories. Suppose I take 5 grams of glucose, table sugar, it gives only 20 kilocalories. But the calorie is not the matter, the fructose is the matter. I will just tell you why fructose is very, very important. Fructose goes liver via portal circulation, it bypasses one step, no regulation, so rapidly metabolized. It is rapidly metabolized. And beta cells, fructose does not stimulate, okay, so though no insulin involvement, okay. And leptin not stimulated, so appetite not suppressed, so no feedback inhibition. So automatically it goes on its own way, okay. So that's why long back, 4 or 5 years back, they have this no sugar sweets. They added fructose actually with fructose, but later on they found that all the people have developed fatty liver. That's why they just block that. They are not selling it, okay. How much fructose we can consume? This is very important thing you have to. So low risk means 20 to 30 grams, okay, 20 to 30 grams, okay. 2 fruits, okay, acid as fiber. 2 fruits daily, you can have 2 fruits per day. Then moderate is 50 to 6 okay. Sugary drinks, desserts. Now the summer season, everywhere sugary drinks only. That's a really bad thing. But you cannot do this. Business people, you can't. They only rule the country, you can't block them. That's the problem. Then high risk fatty liver risk is 60 to 80 grams per day. And 2 to 3 soft drinks, sweet 70 grams, easier சாப்பிடலாம். ஒரு 2 sweet சாப்பிட்டு ஒரு 2 drinks சாப்பிடணும் வச்சுங்க, முடிஞ்சு போச்சு. So you have surpassed the limit, okay. So you have to be very careful in taking cool drinks, okay. Youngsters for everything cool சாப்பிடணும்பாங்க, okay. So now no sugar drink, something has come, latest. Some carbonated drinks, no sugar, something has come, okay. Whole fruits is better because it's you should not have, see, juice also should not take because sugar should not be added, okay. Then whole fruit only, sweet liquid, rapid absorption, automatically you are solid. Then slow absorption, avoid table sugar, corn soup, high risk diabetes, obesity, okay, right. Nephrodite, pre-dialysis 0.6 to 8 grams, and okay, that's okay. Avoid red meat and excess pulses in case of renal patients, okay. These are the fruits, apple, grapes, okay, cabbage, this okay. Rice-based foods is preferred for the renal patients, rice-based foods. Okay, this I think, this is the last slide, just this is my own. How to avoid stress? Most of the people undergo stress. What is how to avoid the stress? We are there is failure to accept failures. We don't want to accept failures. That's a very important thing for stress, okay. You want everything to be positive and you want everything to be done immediately. Both are not possible, okay. There are innumerable factors involved in this, okay. So when you have acceptance, when you have patience to get the things done, you'll have a less stress. And another thing, we always compare with others, Now most of us see other fellow, this car has bought, he has got Audi car. We see only that. But life is not an Audi car. How is your family? How is your children? How is your husband? Okay, all these factors matter a whole life. So when you compare with the whole life, it's not possible, okay. So don't analyze others. Don't compare yourself with others. Always you think about what you can do and how you can feel happy. That's the important thing, okay. So never compare with others, okay. That's the thing, okay. Success, another thing, suppose I want to get a medal, something like that, you should not get stressed. Simply work. Even if you don't get medal, okay, no problem, okay. That means you have you are accepting your anything, any outcome you are accepting. That means you have full free mind. So when you go for exam, pass ஆகும், you get stressed, எல்லாம் மறந்து போயிடும். ஆனால் போய் அடுத்த எழுதிக்கலாம், அப்படியே போனேன்னு வச்சுங்க, automatically you get everything, you remember everything, automatically you get through. So you should not get stressed on this, okay? How to peaceful then? Let us plan, work with free mind without. Another important thing is, whatever you do it unconditionally. You love unconditionally, read unconditionally, eat unconditionally. If you do everything unconditionally, you will get all the benefits. But we always put conditions first, then you go for work. That's the important thing for the stress, okay? So, with this, I just conclude my talk. I'm happy for peaceful listening. So, I hope some of the things may follow and keep you healthy, okay? God bless you. Thank you.
Thank you, sir. There is a vast explanation regarding the cellular energy dynamics and the metabolic functions. He mentioned about mostly biochemical. Whether you all understand, anyway, you take the take-home message. Take 3 years without stress. Thank you. The topic is open for discussion. Anybody wants to know anything, can ask the speaker. Anybody? Any volunteers? Anybody wants anything? Either biochemistry or related with this nutritional base? Any volunteers? If it is any volunteers? If it is not, we can close the session. Thank you, sir, for explaining speech. And I don't want to say anything. He is my guide, me is a master, everything for me. Without him, I am not here. Thank you, sir. Thank you so much.
Thank you so much, sir.
Can close the session.
I now request our chairperson, Dr. Inmori ma'am, to felicitate our speaker, Dr. Sethupathi sir, with the token of her appreciation.
I would also like our organizing chairman and HOD Physiology, Dr. M. Sudha ma'am, to felicitate our chairperson, Dr. Inmuri ma'am. Hard copy of Thank you, sir. Thank you, ma'am. Roshni, don't you think before we move on, we have a task pending from yesterday?
What did we leave out, Sakshi?
We are yet to award yesterday's post-test winner top scorer.
Truly said Sakshi. With that, we announce the delegate with the maximum mark in yesterday's post-it, Dr. Jami Patricia ma'am. To felicitate our topper, we invite Dr. Rekha ma'am, head of, and Anu ma'am, to felicitate our topper.
We welcome you, ma'am, with a huge round of applause. I would also like Dr. Jemi ma'am to grace us with a few lines of wisdom.
Thank you so much for this honor, and I would like to express my heartfelt gratitude to the faculty members of Cuddalore Government Medical College and also to the organizers of this Anandha Thandava. This wouldn't be possible without the constant support from my department and my beloved ma'am, Dr. Deepa Lakshmi, head of the department, PhD MSR, and also I would like to thank my co-PGs and my junior PGs for this motivation. Thank you so much.
Moving on forward, we are honored to invite our chairperson for the second session to the dais. It is a privilege to welcome Dr. Mahendran Sir, Professor in the Department of Anesthesiology at Government Cuddalore Medical College. Sir, we humbly request you to chair the session and on the topic of bioelectric potential and introduce and invite our distinguished speaker, Dr. S. Anu ma'am, for this lecture.
Good morning to all. Thanks for inviting me to chair this session. I'm really privileged to be present here with the doyens of basics of anatomy, physiology and biochemistry. Now I welcome Dr. S. Anu ma'am, Professor and HOD, Physiology, Vellamal Medical College, Madurai. She has 21 years of experience across several medical colleges of Tamilnadu. She has published 30 plus research articles in index journals. She has been a reviewer for reputed journals, and she has been very active in medical education programs. She has organized national and international conferences, CMEs and workshops. She has guided ICMR STS projects and university rank holders. Please welcome ma'am.
Good morning, everyone. Thank you for the nice introduction, sir. Thank you. At the outset, I would like to thank Dr. Sudha ma'am, the organizing chairperson, as well as the head of Department of Physiology, for giving me this wonderful opportunity. Thank you, ma'am. And I'm also very happy to see here my student, I would say a student as well as friend, Dr. Prem. He's from Vinayaka Missions. When I was working as a teacher there, she was there, Dr. Prem. Nice to see you, Prem, here. And one more happiness is nice to see Dr. Rekha, my colleague in Vellamal Medical College. Now she is the professor head in next speaker. She's going to be. Thank you for the opportunity, ma'am. Thank you. Let me start with today's topic, bioelectric potentials. Prem? No. Okay. How many PGs are here? Can you please raise your hands? Okay, thank you. In a human body, how much is the water percentage, total water percentage? In the human body, normal average water percentage? 60 to 70% is the water level, and it is full of ions or electrolytes. It is with ions or electrolytes. And why we are talking about this is body is a good conductor of electricity. You have full of ions roaming around producing electric signals. That is why you need these electric signals. Why ions should be or electrolytes should be present within the body. Why do you need this? because my heart functions as an electrical activity. My functioning of the heart, beating of the heart, nerve communication with each other, for the muscle contraction, everything, we need the bioelectric potentials. And all these bioelectric potentials, you can see the bioelectric potentials inside the body. They are nothing but electrical voltages. Bio is biological organisms and potentials is the voltage differences. So, or electrical voltages generated by ionic currents within the living cells. And these biopotentials are recorded using electrodes, which converts these ionic currents which is flowing inside into electrical signals. That is what in physiology we record as EMG. EMG is electromyogram, electrocardiogram. So all your instrument-based investigations are based mainly on these biopotentials. Initially, they recorded these biopotentials in the squid axon, because the squid axon, the diameter is 20 times more than that of the human being axon. The squid axon has a diameter of about 20 millimeter, larger one, easier to record the electric potentials. Apart from that, cuttlefish, many other species were used. Now, what are biopotentials inside the body? What are the biopotentials we are going to discuss in today's lecture is, one is resting membrane potential. If the stimulus strength is enough, it produces another one called local potential. Then action potential. The last one we are going to discuss about is compound action potential. All the living cells in the body have resting membrane potential. All the cells have resting membrane potential. Which cells are known as excitable cells? Any idea? Every cell has resting membrane potential. There are potential differences across the cell membrane. Which cell do we call them as excitable cell? Yes, PGs. Any cell which is capable of producing an action potential. Any cell which is capable of producing action potential, we call them as excitable cells. All the other cells come under the category of non-excitable cells. Non-excitable cells do have resting membrane potential and they do some purpose locally. They also have a purpose, resting membrane potential. Now this we all know. What is the ionic composition between the extras? What is the structure? This is cell membrane and this is outside of the cell. We call this fluid as extracellular fluid and this is intracellular fluid. Can you name the predominant cations and anions in the extracellular fluid? Sodium, excellent. The composition of seawater, isn't it? Sodium and then predominantly chloride ions. Inside of the cell, the predominant cation is positive ion is potassium and anion is phosphates. Your first answer should be phosphates, proteins, sulfates, nucleic acids. All these are anions inside the cell. And what you have to know here is the proteins are not diffusible. All these ions are diffusible. What do you mean by diffusible? They can cross from one side to another side. Proteins, because of their larger size, one of the reasons they are not diffusible across the membrane. Now this tabular column shows the composition, the concentration of the most important ions in the ECF and ICF. These values I had taken from Ganong. These are all approximate values. It varies with the books. Now, sodium, the extracellular concentration is 150. I want you people to remember these values. And intracellular is 15. Very easy to remember these values. And potassium, the extracellular is 5 milliequivalents. Here it is given as millimoles because the valency is 1. There's no much difference. It is also milliequivalence. So potassium 5 and intracellular 150 milliequivalents. Chloride extracellular is 125 and intracellular is 9. Now look at the next column, relative permeability. Which ion has more relative permeability? The ease with which it passes through the membrane. Which ion do you think here has more permeability. Potassium, 1. The permeability is 1. What about, which is next in order? Is it sodium? Chloride. Next in order is chloride. The next will be the sodium ions. So which ion has more permeability in an excitable cell? Potassium. Your answer should be potassium. And these are the equilibrium potentials. Potassium ion equilibrium potential is minus 90. Sodium is positive 60. Chloride is negative 70 milliohms. This again a small recap. You all know this. What does this picture depict? Different types of channels. You all knew about this. And this, the first one is a leaky channel. What do you mean by a leaky channel? A channel which doesn't have gates, which is always open. Ions can flow in any direction. This is called leaky channels. Leaky channels are abundant for which ion? Just now we discussed. The one which is more permeable, more diffusible. Potassium ions. Abundant leaky channels for potassium ions. And the next one is the voltage gated channel. When there is a voltage change outside, the channel pore will open, allows ion to enter inside. This is called voltage gated channel. Another one important channel is, what is this? Ligand gated channel. For example, in neuromuscular junction, do you remember? Acetylcholine goes and binds with its receptor, allows sodium to enter inside. This is ligand gated. So ligand gated channel. A neurotransmitter or hormone binding with the channel allows ions to move inside. So basically we have leaky channels, we have voltage gated channels. Leaky channels are very important for resting membrane potential. Voltage gated channels are very, very important for which potential? Action potential. Excitable cells do have voltage gated channels. That is the reason we get action potential there. So next, okay. Now, resting membrane potential. What is resting membrane potential? I could see here. It is a membrane potential. The difference of potentials across the cell membrane. Resting stands for at rest, when a cell is not excited, when it is not given any stimulus. In a resting cell, the inside of the cell membrane is negative and outside of the cell membrane is positive. This is only along the cell membrane, not within the cell or outside the cell. Within the cell, you have equal number of positive, negative ions. Outside, equal number of positive, negative ions. This difference is present only across the cell membrane. Inside is slightly negative, outside is slightly positive. And please do remember, only very small number of ions contribute to this potential. Right? This is called resting membrane potential. Inside negativity. Inside refers to the cell inside. This state is otherwise called polarized state. Resting membrane potential stage or polarized stage. Right? Once again, I'll define resting membrane potential. It is the potential difference across the cell membrane at rest, with inside being negative and outside of the membrane being positive. This is the resting membrane potential. What is the resting membrane potential of a neuron? We all knew these values. RMP of a neuron is negative 70 millivolts. And RMP of skeletal muscle is negative 90 millivolts. Cardiac muscle is minus 90 millivolts. Some tissues like smooth muscle, pacemaker cells, etc., they have unstable resting membrane potentials. This is a stable one, fixed one. The value is the same almost. Whereas some cells have unstable resting membrane potentials. Right. Now, imagine a hypothetical situation where there is a cell and outside, this is ICF, this is ECF. Right? Everywhere equal number of cations and anions are present. Here also anions and cations are present. Equal amount of positive, negative ions. Can you record any electrical difference in this case? Yes or no? I keep one electrode inside, one outside, and I try to record it. Will I get any deflection in the galvanometer? Rendu pakkamum neutral ah irukku. I won't get any electrical potential, isn't it? So it is like that. Imagine a situation like this and imagine the potential is zero, no potential is there. ஒரு imaginary situation na எந்த பொட்டன்ஷியலும் கிடையாது உள்ள ஜீரோன்னு இருக்கு. Do you understand? What is the RMP of a neuron? Negative 70 millivolts. Now I have taken a cell which has zero potential, right? We are going to see how this negative 70 millivolts is created now. What are the ways by which it is created? Number one, which I am going to talk about is this is cell interior, cell exterior. This is the cell membrane which has got which pump? Sodium potassium pump. We all know about this pump. It is present in the cell membrane of all the cells. And what does it do? Why this is electrogenic? Because it separates the charges across the cell membrane. Electrogenic pump. And what does it do? Yes, PGs. What does electrogenic sodium potassium pump does? Pumps out sodium outside and in turn takes in potassium inside. So it pumps 3 positive ions outside and takes in 3 positive, is it 3? 2 positive ions inside. 3 positive வெளியே போய் 3 positive உள்ள வந்துச்சுன்னா ஒரு சேஞ்ச் இருந்திருக்காது. Now what this pump is doing is it pumps out 3 positive ions outside and in turn takes in 2 positive ions inside. What will happen to the polarity of the inside of the membrane now? Just inside of the membrane. Will it become slightly negative or positive? Negative. Can I say sodium potassium pump contributes a little to the RMP? Can I say that? Yes. It contributes to around minus 4 millivolts. Value varies with the books, minus 4, minus 5, etc. Very little. Actually, we would say it helps in maintenance of RMP, but as of now, an imaginary situation, you remember, from 0, sodium potassium pump has increased the membrane potential to how much? Minus 4. So what is the sodium pump doing now? It is creating electrical difference across the membrane with inside slightly negative. Number 2, it keeps the concentration of which ion higher inside? Sodium வெளிய அனுப்பிருச்சு. உள்ள எது எடுத்தது? Potassium. So it always keeps the concentration of potassium high. அங்கே தான் இருக்கணும். So it keeps the potassium concentration inside very high and sodium concentration outside also high. That is the role of the sodium potassium pump. So from 0, we know now this has raised it to minus 4 millivolts. இது இவ்வளோ தான் contribute பண்ணுது. Now another situation again. This is again a cell and exterior. What is the potassium concentration inside the cell? நான் கொடுத்த values 150 milliequivalents per liter. And what about EC of potassium? 3.5 to 5. We keep it as 5 milliequivalents per liter. So 155. Now what will be the concentration gradient of potassium now? Ulla 150. Veliya 5 milliequivalents. We know that ions will always flow from high concentration to a region of low concentration. Now potassium is high outside, inside the cell and low outside. What will be the direction of flow of potassium ions? From inside to outside or outside to inside? Inside to outside. So the potassium will try to move from inside to outside. Potassium is a positive or negative ion? Positive. So when positive potassium moves outside, the inside of the membrane will become again slightly negative. And outside of the membrane will again become slightly positive. We call the state as again resting membrane potential or polarized state because potassium moves out. Now, among the 3 important ions which I have started with, which is the most diffusible, permeable? Potassium ions. That means the potassium ions has more number of leaky channels. RMP, always remember, it is contributed mainly by leaky channels, right? Potassium has significantly higher number of leaky channels than sodium channels. So more number of potassium goes outside and inside becomes gradually negative. This potential which develops due to the diffusion of potassium outside, we call it as diffusion potential also. So negativity gradually build up ஆயிட்டே இருக்கும் till it reaches a value of minus 94 milliohms. Till it reaches a value of minus 94. What about sodium potassium pump? Minus 4. What is the role of potassium? How much does it contribute? Minus 94. What is the RMP of a neuron? Negative 70. So look at this. Potassium is high inside because of sodium potassium pump, low outside, and the potassium has abundant number of leaky channels. So we know that potassium always moves from higher to lower concentration gradient. As it moves out through the leaky channels, again, the interior of the cell becomes negative, outside of the cell membrane becomes positive. And it contributes to our resting membrane potential of, sorry, minus 94 milliohms. Now the last cell. So far we have discussed about sodium potassium pump, the movement of potassium via leaky channels. The third situation is again an empty cell. இங்கேயும் நம்ம ஜீரோனே வச்சுக்கலாம் potential. ஜீரோல தான் இருக்கு. Now we will talk about sodium ions. Sodium ions also have leaky channels in the cell membrane, right, next to potassium. And then outside sodium concentration is very high, 150. Inside sodium is less, 15 milliequivalents. Now what will be the direction of movement of sodium? Outside to inside. So the concentration gradient is towards the inside of the cell. Sodium moves into the cell. So inside becomes slightly positive. But the number of sodium channels, leaky sodium channels, is less compared to potassium. என்னன்னா உள்ள positivity கொண்டு வந்தாலும் it doesn't raise it to 70-80 millivolts. The positivity reaches an approximate value of how much? All these are approximate values. Plus or positive 8 millivolts. So empty cell, sodium potassium pump contributes negative 4. Potassium alone contributes negative 94. Sodium alone contributes plus 8, positive 8. Now we'll come to the real scenario. This is a cell. The membrane is permeable to all the ions. Sodium, potassium, chloride, calcium, everything is permeable. But the most diffusible one is potassium, right? So potassium is moving outwards, creating negativity. What is the value? Minus 94. Sodium is moving inwards. It is trying to move inwards, creating positivity inside. What about chloride? Chloride is high outside or low outside? High outside in the ECF. Will chloride try to move inside because its concentration is less in the ICF? It will try to move inside. But inside negativity is very high, so chloride is repelled. Do you understand? So it doesn't have role in this RMP. It is in the RMP. So, and inside the cell we have plenty of negative charges, anions, proteins contributing to the negative charges. So because of all these combined factors, right, we get the resting membrane potential. My question is, for example, the resting membrane potential of a neuron, I said negative 70 milliohms. Among all these ions, which creates the resting membrane potential close to the RMP of a neuron? Potassium, sodium pumpa, edu, chloride, anions, potassium. So the resting membrane potential of a neuron is always close to potassium diffusion. Potassium diffusion. We'll talk about this later. That's just a simpler version. See? 94 plus 80, right? RMP is minus negative 70 milliohms. Why potassium ion is more permeable when compared to sodium? Potassium ku nariya leaky channels irukku, sodium ku leaky channels irukku. Irundhalum why potassium is more permeable? Number is more, accepted. What else could be the reason? Look at this. The atomic weight, forget about this. The radius, the hydrated radius of potassium is how much? 0.12, whereas sodium is 0.18, which can easily pass through the membrane, channel. Sodium or potassium? Hydrated radius is less for potassium. That is the reason it also, conductance is more, its diffusion is more via the channel, right? You can see this picture. This is a leaky channel where there are no gates. Potassium is trying to move inside, right? Sorry? Now, this is the selectivity filter. Potassium is trying to move, right? This is the selectivity filter for potassium. This selectivity filter easily removes the water molecules attached with potassium. Potassium water oda சேர்ந்து தான் உள்ள போகுது. போறப்ப அந்த water molecules எல்லாம் it is removed by the carbonyl groups present in the selectivity filter so that it can easily move. Whereas when you take the sodium channel, the geometry is little different, so it is difficult for the hydrated sodium to pass through easily. Do you understand? There are many reasons behind that. I don't want to talk here. So please remember the hydrated radius for sodium, for potassium is less. That is why it can easily diffuse. Potassium has more number of leaky channels and the radius is less. That is why potassium is more permeable. You can see here, this selectivity filter has carbonyl oxygen groups, which removes the water molecules. Genesis of RMP. Number one, I would say instead of selective, differential permeability of the cell membrane to various ions. Potassium ku nariya, sodium ku adha vida kammiya. So RMP is number one due to differential permeability of the cell membrane to various ions. The other things which we are going to see today is how we derive Nernst equation, Goldman's equation. RMP is also contributed by sodium potassium pump, and a slight negativity inside the cell is also contributed by Gibbs-Donan equilibrium, right? So na ipa solradhu ellame yen inside there is slight negativity, that is contributed by all these mechanisms. Now this is intracellular fluid, extracellular fluid. We have potassium channels, right? What is the direction of movement of potassium? Inside to outside. Very good. So potassium moves out due to concentration gradient. So inside of the membrane becomes slightly negative, outside of the membrane becomes slightly positive. We know very well about this. That is the main reason for RMP. So potassium is trying to move out because of which gradient? Concentration gradient or electrical gradient? Only concentration gradient. Because it is high inside and low outside, this potassium is trying to move. So this is moving out because of concentration gradient. After a few minutes or few seconds, when this positive potassium is moving out, because this inside is becoming negativity, this negativity prevents further efflux of positive potassium ions. நீ நிறைய போயிட்டா நான் நெகட்டிவாக தான் இருப்பேன், ஸோ உன்னை வெளியே அனுப்ப மாட்டேன். ஸோ திஸ் negativity prevents further movement of positive potassium ions. So one point, so can you see here? The electrical gradient will be reversed inside, right? So there is one point at which, because of the equal forces, concentration gradient, idu inda pakko, electrical gradient and the pakko, there is no net movement of ions, there is no flow of ions, and this point we call it as, yes, PGs. Yes. Concentration gradient nala velila pogudhu. Electrical nala ulla vara try pannudhu. Mothathila flow stop ஆயிருச்சு. What is this potential called as? Equilibrium potential. Very simple. The point at which the opposite forces act, we call this as equilibrium potential, right? The equilibrium potential value of potassium is how much? Minus 90 milliohms. It is minus 90 milliohms. We will try to derive the equation. I think you all would have read in the first year itself. Equilibrium potential for potassium is this value 2.303. R stands for, yes, gas constant. T stands for temperature. Z stands for valency of the ion, plus or minus, and F stands for Faraday's constant. All these have constant values. Temperature doesn't vary much. So idellame constant values irukku. Idu mattum marum. Z mattum marite irukum. Chloride na it becomes negative, potassium na positive. All these are constants. And what is this ln? Natural logarithm. ln is natural logarithm. And this is concentration of the ion outside divided by concentration of ion inside. Now, this formula is converted like this. When you convert this natural logarithm to the log base 10 or normal logarithm, very simple. When you convert this natural logarithm to the normal logarithm, all these will be replaced except z. In the ellame, it is replaced with which value? 61.5 log. It is all replaced. You can also add plus or minus 61.5. I haven't added specifically, I'll tell you why. So all these are, did you understand this? Is it clear? 2.303 irukku. இதெல்லாமே constants, gas constant, temperature constant, Faraday's constant. இது natural logarithm. All these are finally converted into which value? 61.5. Divided by which is remaining? Z, the valency is remaining. And this has become log to the base 10, or everything is the same. Log of concentration outside by concentration inside. This is the final formula we derive. Now plus, 61.5. Why did I add plus here? The valency of potassium is positive. By Z irukku illaya, adukku badala and the valency na add panniten. It has become plus 61.5 log of concentration by 5 by 150. Potassium outside by potassium inside. What is the value you get? Logarithm negative 1.47. When you multiply this, you get a final value of how much? Around minus 90 milliohms. This is how we get the equilibrium potential of potassium. Did you understand this? What is the equilibrium potential? The point at which, for any ion, diffusible ion, the concentration gradient force is opposite to electrical gradient force. So net flow stops. This is called equilibrium potential. Each ion has got equilibrium potential. For potassium, the value is how much? Negative 90 milliohms. Shall we derive this for sodium also? Yes. Sodium, the movement is from, the concentration gradient movement is from outside into the cell. And when sufficient positivity enters inside, the negativity created outside prevents further influx of sodium inside. So a point is reached at which the flow once again stops. Right? That is called equilibrium potential for sodium. Again, the same formula. What is the valency here? Only thing is we have to substitute the valency. Valency is plus 1. Plus 1. 61 plus 61.5 into log of 150 by 15 is plus 1. Okay. So what is the final value? Plus or positive 61.5 millivolts. You can roughly keep it as plus 60 millivolts. So equilibrium potential for potassium is negative 90. For sodium is positive 60. Likewise, you can also derive for chloride ions. What is the value? Very simple to calculate this is. Minus 70 milliohms. Chloride, it is minus 70 milliohms. Can you repeat the values? What is the equilibrium potential for potassium? Minus 90, negative 90. Sodium, plus 60. Chloride, minus 70. Equilibrium potential of which ion is the same, almost the same as RMP of a neuron? Chloride. Why? We'll discuss this. Can chloride come into this cell? Come into this cell? In a ulla negativity irukku, it prevents the entry of chloride into this cell. So there is no movement of chloride at all. So we cannot take into consideration chloride because its equilibrium potential is the same as that of the RMP of a neuron. Now, resting membrane potential is the weighted average of equilibrium potentials of potassium, sodium, chloride and so forth. The weighting factor is the fraction it contributes to the total ionic conductance of membrane. Potassium negative 19 சொல்லியிருக்கேன், sodium plus 8 சொல்லியிருக்கேன். சோடியமும் உள்ள வருது, பொட்டாசியமும் வெளியே போகுது. பட் ஏன் பொட்டாசியம் தான் கான்ட்ரிபியூட் பண்ணுதுன்னு சொல்கிறேன்? Because the permeability of which ion is more? Potassium is more. So the explanation is this only. The weighing factor is the fraction it contributes to the total ionic conductance of the membrane. Did you understand this? We talked about RMP, minus 70 millivolts in a neuron. It is contributed mainly by, what should be your first answer now? RMP is contributed by efflux of potassium ions. This should be your first answer because its concentration is high inside and it has more number of permeable leaky channels. And next you can add upon the role of sodium, potassium pump, everything, right? Why is RMP necessary in a cell? RMP illama kuda irukalaamla. Why is RMP necessary in a cell? When RMP is there only you can fire an action potential. Otherwise you won't get an action potential. So at rest in a neuron, can you see here? What does this negative 70 indicate? Resting membrane potential of a neuron. What is this potassium trying to do? In the resting membrane potential, எந்த value எடுத்துட்டு போக try பண்ணுது? Equilibrium potential of potassium. Is it successful? Nearly. கிட்டத்தட்ட ஆனா ஃபுல்லா கொண்டு போகல. And what about sodium? It is trying to take the RMP to its equilibrium potential. What is the equilibrium potential of sodium? Plus 60. ஒன்னு அதனோட equilibrium potentialக்கு கொண்டு போக try பண்ணும். Do you remember the action potential curve? Sodium moves inside, minus 70 ல இருந்து 0 போகும், overshoot ஆகி 30 வரைக்கும் போகும், but it doesn't go up to its equilibrium potential, isn't it? Every ion will try to take the RMP to its equilibrium potential. Chloride, it just follows it, it doesn't have any role in this. So potassium is 50 to 100 times more diffusible than sodium. So we discussed about RMP, we discussed about equilibrium potential. Equilibrium potential of a single ion with the single valency is univalent ion is calculated by which equation? Nernst. ஒரு potassiumக்கு தனியா, ஒரு sodiumக்கு தனியா, ஒரு chlorideக்கு தனியா. Equilibrium potential of a single ion, univalent ion, is calculated by Nernst equation. Now this is a derivation of extension of the Nernst equation, Goldman-Hodgkin-Katz equation, where this equation takes into consideration ஒரு அயானும் தனியா ஒன்னும் contribute பண்ணல, ஒரு cell membrane ல நிறைய ions போயிட்டு வந்துட்டு இருக்கு. So equilibrium potential, it takes into consideration the concentration differences of all the ions. The brackets indicate concentration difference. Not only that, the permeability of all the ions. It takes into consideration the concentration gradient and permeability of here 3 ions. ஒரு ion இல்ல, எத்தனை ions? எல்லா ions நான் எடுத்து பார்க்கிறேன். Do you understand? ஏன்னா cell membrane is permeable to all the ions. So I take into consideration all the ions. The concentration as well as the permeability. P stands for permeability. This is for concentration. But ideally, restல என்னதான் எல்லாத்தையும் எடுத்தாலும் the value is close to which ion? At rest, இதுக்கு பெரிய வேல்யூ இல்லை, இதுக்கு பெரிய வேல்யூ இல்லை, it is close to potassium only again. Do you understand? In a resting cell. So other than this, you have many equations. We have a cord conductance equation which has a role in resting membrane potential. Again, that is a weighted average of equilibrium potentials of all the ions and also taking into consideration not the permeability but the conductance. Permeability na evlo open channels irukku avladhaan. இதுக்கு conductance is ion current. Do you understand? Goldman takes into account permeability. Cord conductance equation takes into account conductance, right? I'm not elaborating much. The third one which is contributing to resting membrane potential is Gibbs-Donan equilibrium. Anyone has idea what is Gibbs-Donan equilibrium? Yes? PGs? It is mainly due to the presence of, there is differential distribution of ions. Equal alama இந்த பக்கம் வர மாதிரி, இந்த பக்கம் வர மாதிரி. It is due to, because of one impermeant or non-penetrating anion or cation? Anion. Proteins. It is due to anions of proteins. These are the pictures I have taken from the net. This is a picture. There are two compartments separated by a cell membrane. This compartment ECF has equal number of potassium and chloride ions. This again has equal number of potassium and chloride ions. I'm not going into the detail of this. I'm just going to say how this is contributing to RMP. That's it, right? Equal number of positive, negative, equal number of positive, negative ions. Now, if you substitute this intracellular compartment with proteins, oh, this is intracellular. If you substitute this intracellular compartment, potassium chloride. Now, if you substitute with proteins inside the cell, we know inside the cell has more proteins, which is impermeant. So, if you substitute the proteins here, now, what will be the chloride level in these two compartments? Enga concentration relative higher irukku. Modalla equal ah irundhuchu. Ipo protein substitute பண்ணிட்டீங்க. Chloride concentration enga irukku illa. There chloride concentration is high relatively, here no chloride. Do you understand? So the concentration gradient favors the diffusion of chloride from high to low. Chloride diffuses to this side where proteins are present. This chloride also attracts, and the electronegativity nala, it attracts positive potassium also into this cell. So the side where the proteins are present, look at this picture, the side where the proteins are present, what is happening? More chloride is coming inside. Following that chloride, potassium is also coming inside. Finally, one stage is reached. Equal cation, equal anion. Ingyu equal cation, equal anion. But what is happening to the osmolar concentration? The side with proteins have more number of ions. Here, less number of ions. The presence of a non-penetrating ion or impermeant protein favors asymmetrical distribution of diffusing ions, potassium, chloride, etc. So inside has slightly more negativity compared to outside. In a way, this also contributes to resting membrane potential. So Gibbs-Donan effect is it contributes to electrical difference across the membrane potential difference, and this also leads to cell swelling. Ena one side la osmolar concentration is more. That is prevented by continuous activity of sodium potassium pump. You can read it in your books, all those things. So this is a Gibbs-Donan effect. Recording of RMP, we all know that using micro electrodes. You keep one electrode outside, one inside, record the potential difference, you get the resting membrane potential. Apart from micro electrodes, we can use cathode ray oscilloscope, which can record both RMP and action potential, and many new techniques are there to record the resting membrane potential. Under RMP, the last question. A researcher is studying the RMP of an isolated nerve fiber. The measurement that he obtains of the RMP is -70, normal RMP. Now, he adds potassium to the fluid in which the nerve fiber is placed. What is happening now? Hyperkalemia or hypokalemia? Potassium add pandrar. Appa enna agudhu? That is hyperkalemia. What will happen to RMP in hyperkalemia? You have to answer. Normally, potassium movement is towards? Normally, potassium keeps moving outside, creating negativity inside. Potassium poite irukum. Ipa ECF la more potassium is present. Is there a way for this potassium to move out now? Veliye nariya irukku. Modalla kammiya irundhuchu poitu irundhudu. Ipa inside ECF more potassium is present. So potassium cannot move out. So inside of the cell becomes slightly positive. It doesn't reach the threshold level, it is close to the threshold level. So it keeps the sodium gates inactivated. Do you understand? So initially you have a depolarizing effect, but later there is depolarization block. Can you understand this? Potassium, when there is extracellular increase in potassium, Potassium from the cell cannot move outside. It remains inside. Inside becomes slightly negativity. Closer to the threshold, it depolarizes the cell. But it cannot continue depolarizing the cell because the gates are, sodium gates are inactivated. So after some time, there's a block. It remains in an inactivated state. This is about hyperkalemia. What happens in hypokalemia? At least this is easy for you. When outside potassium is less, what will happen? Potassium poguma ulle irundukuma. More potassium will try to diffuse outside. When outside potassium is less, romba kammiya irukkarnala, more potassium will try to diffuse out. So inside is gradually become more and more negative. We call this state as polarized state. Adhigamaite pogudhu. What is this called as? Hyperpolarization. This is called hyperpolarization. Which state is easy to excite a cell? Depolarization or hyperpolarization? Depolarization. இப்போ இங்க என்ன ஸ்டேட்ல இருக்கு ஹைப்போகேலிமியால? Hyperpolarization. Very difficult to excite this cell. Do you understand? அதனால தான் muscle weakness, heart weakness, all these are coming. There are many reasons. And the hyperpolarization can activate cyclic nucleotide channels which favor sodium potassium entry, which can lead to cardiac arrhythmias. பின்னாடி போனீங்கன்னா நிறைய ஸ்டோரிஸ் அதில் இருக்கு. At least I want you to know hypokalemia, nerve is less excitable. Hyperkalemia, nerve is initially excitable. Later it becomes less excitable. That's what you have to know. 1 or 2 MCQs for you too. Which ion plays the most significant role in establishing resting membrane potential? Potassium. What is the Nernst equation calculate for an ion, for a single ion? Which word is very important for Nernst potential? Equilibrium potential. So what should be our answer here? Membrane potential required for equilibrium potential. The next topic which we are going to continue is local potential. So far we discussed about the membrane potential, negativity inside, positivity outside in a cell at rest, and the origin of generation of this RMP. We discussed about the role of potassium ions, sodium potassium pump, Gibbs-Donan, all these things. The next thing which we are going to discuss, the local potential, is number 1, electrotonic potential. And when the stimulus strength is sufficient enough, it can lead to the higher level, graded or local potentials. What is the name of the local potential which is produced at the synapse? Okay, what is the name of the local potential which is produced at neuromuscular junction? Staff should not answer. Yes? Huh? TGs? End-plate potential. The local potential produced at neuromuscular junction is end-plate potential. What is the name of the, I'll give you a clue. Excitatory or inhibitory potential produced at the level of synaptic junctions. Excitatory postsynaptic potential or inhibitory postsynaptic potential. Can you see here? This upstroke, you are giving a stimulus here. You are giving a stimulus here, for example. Now what happens? Which ion is moving inside? Common in the ion. Stimulus kudutha? Resting la potassium. When you are giving a stimulus, when you are exciting, which ion? Sodium. Main calcium ellam varum. But I am talking about a nerve here generally. So sodium enters inside. Through which channel sodium enters inside? Is it the leaky channel? Or ligand gated channel? Mechanosensitive channel? Or voltage gated channel? Action potential na mattunna you have to talk about voltage gated. Now we are talking about local potential. What are the channels do you think are involved? For example, neuromuscular junction. Ligand gated channel. Acetylcholine binding with the receptor, sodium enters inside. Ligand gated. If it is in the case of receptor, Pacinian corpuscle, you press it, give pressure, sodium enters into the unmyelinated nerve ending, produces local potential, receptor potential, isn't it? What channel is that? Mechanosensitive channel. So the local potentials are due to the entry of in a neuron, mainly due to sodium, either via Either via, what are the two types of channels? Ligand-gated channels or mechanosensitive channels, right? So this sodium enters inside and it is trying to bring the inside to positivity, but it is not, if the strength of the stimulus is not sufficient, it cannot reach the threshold of minus 55. It remains in the local state called local potential. Ange da irukum, local potential, excitatory potential, it cannot travel any side, non-propagative potential. Do you understand? This is called local potential. This is excitatory. If the stimulus is inhibitory, imagine in the synaptic junction, like glycine na neurotransmitter varudhu. Appa which ion enters into the postsynaptic terminal? Chloride, isn't it? Glycine is the neurotransmitter, or GABA, for example. GABA, we will take GABA. Which ion enters into the postsynaptic junction? Chloride. So you get a inhibitory postsynaptic potential. So depends on the neurotransmitter, it is either excitatory or inhibitory. ரெண்டுமே இருக்கு அப்படினா எது அதிகமா செக்ரீட் ஆகுதோ, if excitatory is more, then it leads to the action potential. When this local potential reaches the threshold at a level of minus 70, minus 55, generally approximate value in a neuron, when this goes to minus 55, threshold is reached. Only when this threshold is reached, voltage gated sodium channels will open. Till then it is closed, right? So can you see here, these are all excitatory potentials. What is happening here? கொஞ்சம் ஸ்ட்ரென்த் ஸ்டிமுலஸ் கொடுக்குறேன், சின்னதாக ஒரு எக்ஸைட்டேட்டரி வருது. இன்னும் கொஞ்சம் ஸ்டிமுலஸ் ஸ்ட்ராங்காக கொடுக்குறேன், இன்னும் கொஞ்சம் பெருசாகுது. இந்த மாதிரி மல்டிபிள் ஸ்டிமுலஸ் வந்து when all these add together, in all these summate, then it can reach up to the threshold level, either due to temporal or spatial summation. What is this? What is this actually? Is it a local potential or action potential? Local potential. It is due to the entry of sodium via either mechanosensitive or ligand-gated channel. Now, when the stimulus strength is sufficient enough, adequate stimulus or threshold stimulus has the ability to excite a nerve. When the stimulus strength is sufficient, then it reaches which value? Adequate stimulus irundha mattumna it can reach minus 55 millivolts. Once it reaches this area, you can never stop this action potential. It immediately goes up and produces the action potential. Only up to this, we need this, all these things. Do you understand? Now, regarding the local potential, you're trying to touch a person, for example. You're trying to touch a person, a stimulus is given. Initially, when you're trying to touch, the stimulus is mild. Initially, RMP la irukku, now stimulus kudukuren. The first potential that is produced here is called, which potential is it? Kuttiya inga oru depolarizing potential, oru repolarizing potential irukku. What is the name of that potential? It is not due to inflow or efflux of any ions. Endha channel open ala onnume agala. Initially, there's a small potential. This is a potential which is happening at cathode. And this is at anode. What is the name of this potential? Yes, PGs. Electrotonic potential. This potential, initial potential, which is due to just movement of charges, is called electrotonic potential, which rises and then immediately decays. Mandu odane decay aayirum. Within 1 or 2 millimeter, it reduces to 37% of its original value, rises sharply and decays exponentially. So at cathode you get a depolarizing potential, at anode you get a hyperpolarizing potential. Do you understand? Initially it is called electrotonic potential. PG should know this. And when the stimulus strength is sufficient enough, now the ligand-gated sodium channels will open, sodium enters inside and it leads to the production of which potentials here? Threshold இன்னும் போல அப்படி இப்படி வந்துட்டு இருக்கு இங்க இருந்து. What potentials are they? Local potentials or graded potentials. Why do we call them as graded potentials? ஏன்னா நான் strength increase பண்ணிட்டு இருந்தா நான் increase ஆயிட்டே இருப்பேன். Do you understand? That is why we call the local potentials also as graded potentials. Once it has reached the firing level, minus 55, then only it becomes what? Action potential. Right. Sorry. Time. Move agalappa. Just move. So, what type of summation is this? Your strength is not sufficient enough to produce an action potential. So, local potentials nariya produce agadu. They summate to form an action potential. Now, what type of summation is this and what type of summation is this? A single neuron, presynaptic, postsynaptic. This presynaptic frequently stimulates this postsynaptic neuron within shorter intervals. What type of summation is this? Gada submit panna vekkidhu. Temporal summation. Commonest practically is temporal summation. What type of summation is this? 3 presynaptic neurons simultaneously stimulating a postsynaptic neuron, increasing the strength of the stimulus. You get an action potential. This is what type of summation? Spatial summation. What law is this? You give a small, minimal, sub-threshold stimulus, pathala, stimulus strength pathala. You don't get an action potential, but you get a local potential. When the stimulus strength is adequate, sufficient, then immediately you get action potential, right? Even if you increase the strength of the stimulus further, there is no much increase in the amplitude of the action potential. It remains the same. What law is this? All are none law. All are none law is applicable to a nerve. We know that. Is it applicable to a skeletal muscle or skeletal muscle fiber? The whole of the muscle or fiber? Fiber, skeletal muscle fiber. What about heart? Is it applicable to a cardiac muscle or single cardiac muscle fiber? Yes. All the cardiac muscle fibers are connected by gap junctions. So it is applicable to cardiac muscle. The last part which we are going to see today is action potential. So far we discussed about what is RMP, mainly due to potassium. Then we discussed about local potentials, which include electrotonic potentials and exciting inhibitory potentials. Now the next topic is action potential. Before going into that, you should know about 2 types of channels. One is sodium channel, other one is potassium channels. This sodium channel is in a closed state. This is the inactivation gate, and this portion, I'm going with Prem's new concept. So instead of activation gate, here you have the voltage sensors. This closed irukku. When there is a membrane voltage difference, that will be sensed by the voltage sensors, which moves outwards and opens this pore, central pore open pannividu, voltage sensors, right? You have an inactivation gate, and here you have a pore which permits the flow of ions. This is in the closed state, and this is the open state. What is happening here? When you are stimulating, the sodium channels open, the central pore opens, allows the sodium ions inside. What is happening to this inactivation gate? Sodium meduva ulla varudhu. Inge open inactivation gate enna agudhu? It is slightly trying to close. Do you understand? Sodium channel open agara time la irundhu inactivation gate slight close aite irukum. And the gap la sodium will trickle down. Do you understand? So with these sodium channels are time dependent sodium channels. Or a particular time la close ayirum. Do you understand? So sodium ions start moving inside, faster sodium ulla varum. Vandadukku aprom within a few fraction of a second, the inactivation gate will close. Inactivation gate will remain like this. Ipa sodium ulla varuma? Yes, sodium will come into the via the pores, but it cannot leave outside the channel. Do you understand? This is the inactivated state of the sodium channel. Though this portion is open, permits sodium ions, this doesn't allow sodium ions to move out. Do you understand? This is very important, the inactivated state. Now, After sufficient time and rest எடுத்து முடிச்சதுக்கு அப்புறம் again it is coming back to the original state. Inactivation states are fully open. இதுதான் resting state. Resting state, inactivation states, gates are open and this portion is closed. This is the resting state, right? Regarding potassium channel, there is no such problem. It has two states, closed state, open state. அவ்வளவுதான். Closed state, open state. ரெண்டு state தான் இருக்கு. Now this is a curve of action potential. What does minus 70 stand for? Resting membrane potential. Due to which ion? Efflux or influx? Is it moving into the cell, outside the cell? Outside. So it is efflux. Potassium efflux negative 70. You are giving a stimulus here. There's a leaky current, stimulus artifact. After that, because of the latent period, there is a delay. Konjam latent period irukku. Then you get a response. You get a response. Initially, you get what type of potential? Local potential. Electronic varum, local potential. So when you give a stimulus, when the stimulus strength is not adequate, if it is subthreshold stimulus, it opens which type of channel? Adequate இருந்தது அப்படின்னா voltage gated. If it is not adequate, ligand gated or mechanosensitive channel. So these channels open, favor the entry of sodium into the cell till it reaches which level? Firing level. Firing level இல்லைன்னா அதோட முடிஞ்சிருச்சு. Now when this threshold is reached, now what will happen? It opens which channel? Voltage gated sodium channel, right? The pores will open, sodium will try to pour in. Do you understand? This is a positive feedback effect. The entry of sodium ions inside favors further entry of sodium, 5000 times more permeability. So there is rapid, ஏன்னா அதுக்கு ரொம்ப time கம்மி. So channel closes immediately. So there is rapid inrush of sodium into the cell. So when more sodium enters inside, it produces this action potential, upstroke. Voltage gated sodium channels via sodium varappa, it produces this upstroke. This is called as polarized or depolarized. Why depolarized? Inside is now sodium ulla vanduchu, so inside is positive. This is what we call it as depolarized state. Now this sodium entry, it is trying to takes this RMP to the diffusion level, 60 வரைக்கும் கொண்டு போக ட்ரை பண்ணுது. But it stops at the level, there's a peak at the level of 35. Why it stops there? Because the channels close. அதுக்கு டைம் இருக்கு, இந்த டைம்க்குள்ள க்ளோஸ் ஆயிடணும். The channels close. Closure of the sodium channels. Number 2 is this depolarization at around plus 30 millivolts opens the voltage gated which channel? 30 millivolts போயிடுச்சு positive. உடனே எந்த channel open ஆகுது இப்ப? Voltage gated potassium channels. So potassium channels will start opening. Leaky channels already open ஆதான் இருக்கு. So potassium voltage gated channels open, rapid outflow of potassium. So it is coming back to the, trying to come back to the polarized state. So we call this phase as repolarization. Initially the repolarization phase is very rapid, but when it comes closer, there's a short delay. It is not a straight line. There's a short, curve here. There's a delay. This is called after depolarization, which is due to slow potassium efflux. இந்த இடம் தானாவே ஃபயர் ஆக வாய்ப்பு இருக்கு after depolarization, right? And then we expect this curve to stop at RMP minus 70. ஆனா அப்படி பண்ணாம it goes below, it is trying to take this to its equilibrium potential minus 90 வரைக்கும். So it tries to go below. This is called undershoot. This phase is called, what is this phase called as? This is after depolarization. This phase is, it is becoming more and more negative. So after hyperpolarization. Why is this phase required? இது எதுக்கு இங்க இருக்கணும்? Because the neuron should not fire immediately. There should be a gap. The neuron should not get fatigued. அதுக்காக ஒரு ஸ்பேஸ் கொடுத்திருக்கிறது தான் hyperpolarization. Finally, it is coming back to the resting level because of which pump? Sodium potassium pump. So this is the animation. You are touching here, this area. Mechanosensitive sodium channels open. Sodium enters inside. These are all voltage gated sodium channels. This side we have voltage gated potassium channels. Now, due to mechanosensitive channels, sodium is entering inside. This positivity, when it reaches minus 55 milliohms, it triggers the opening of which channel? Voltage gated sodium channel. So sodium channel opens, allows positive charges to move inside. See, inside is becoming gradually positive. You get the action potential above 55. It triggers further opening of the sodium channels to favor entry of sodium ions till it reaches a value of how much? Plus the peak, plus 30 milliohms. At the peak, which channels will open now? Voltage gated potassium channels. See, this opens, potassium moves out. எவ்வளோக்கு எவ்வளோ இங்கே பாசிட்டிவிட்டி பில்ட் ஆச்சோ பொட்டாசியம் வெளியே போகிறப்ப it is again trying to become negative. So potassium moves out till it finally reaches the value of how much? Minus 70 milliohms. This is the action potential. With this curve, I will stop. Can you tell me what is this? I'm giving a stimulant. What is this period? Latent period. What is the first potential which is produced? If it is very minimal, a constant strength stimulus, electrotonic potential. If the stimulus strength is high, we get local or graded potential. And if it reaches minus 55, what is that level called as? Threshold or firing level. Voltage gated sodium channels will open. Sodium ions enter inside, Hodgkin cycle, positive feedback cycle. It is becoming more and more positive. Zero varakum poiruchu. It also overshoots, becomes more positive till it reaches plus 30. At this level, sodium gates close. Which channels will open? Potassium channels open. Polarity of sodium is reversed, everything. And because of that, you get, which phase is this? Repolarization. This is initial repolarization. This phase is after depolarization and then hyperpolarization. This is again because of continuous potassium efflux, hyperpolarization. Coming back to normal because of sodium potassium pump. I will stop with this. Thank you for the opportunity. Thank you. Any questions?
Ma'am, here ma'am. Ma'am, munnadi inge faculty myself. Ma'am, just a few words about what is that? You cannot stimulate it again. What do you call that as?
After hyperpolarization.
Absolute refractory period.
That comes under relative refractory, sir. After
அதை பத்தி அந்த கிராஃப் வச்சு சொல்லிடுங்களா? Previous 2 slides are there. No, just இல்ல ma'am. ஒரு just ஒரு 2-3 minutes. Refractory period. Absolute refractory period.
Okay, you remember the graph now. So in this action potential graph, which phase is the absolute refractory period? இன்னொரு stimulus கொடுத்தாலும் நான் ஒண்ணுமே ஆக மாட்டேன், stimulate ஆக மாட்டேன். I won't respond. Which period is that? Next slide. There's one other slide. Next. அடுத்து. Make it fast. முன்னாடிங்க. Can you see here, from the firing level, when voltage gated sodium channels open, in the peak, இங்கேருந்து 1/3 of repolarization, we call it as absolute refractory period. From the firing level up to 1/3 of repolarization, this is absolute refractory period. You know that all the sodium channels are in which state? Inactivated state. Sodium ulla varala ana pass aga mudiyadhu. Inactivated state. This is absolute refractory period. However the strong stimulus is, you won't excite the nerve. And the remaining portion, this after depolarization, along with mainly this hyperpolarization, up to this we call it as, you can see here, up to this we can call it as relative refractory period. Relative refractory. ஏன்னா இங்கே potassium channels பொட்டாசியம் வெளியே வரது குறைஞ்சிக்கிட்டே வந்துட்டு இருக்கு. ஸோ இட் இஸ் இன் அ ஸ்லைட்லி எக்ஸைட்டபிள் ஸ்டேட். வென் யூ கிவ் அ ஸ்ட்ராங் ஸ்டிமுலஸ் it can excite the nerve, right? Thank you, sir. Anything else?
Thank you so much, madam. The lecture has been phenomenally, exceptionally good. Actually, as an anesthesiologist, we practice both physiology and pharmacology daily in our day-to-day practices. It has been a refresher course for me, actually. We daily deal with all action potentials, all your refractory periods, sodium channels, neuromuscular junctions, everything. Whatever you have discussed, it is purely physiology, but what we as an anesthesiologist, we daily practice physiology and pharmacology. So it has been phenomenally, yes madam, very, very good madam. Thank you so much madam. Any questions from the audience side? Any pharmacology PGs? Medicine PGs? No? Shall I ask one question? Oh, what is the new drug which acts on that leaky sodium channels, which is now currently used in cardiologist, being used by cardiologists? No problem. Thank you. No. No. Sir, answer is you can Google and tell, sir. I just wanted to ask the PGs. I thought like all the PGs were present. Okay. No issues. Thank you so much, madam. Yes. I welcome Celine, madam. I have worked with her for 2 days as NMC inspector. She has been so good in NMC inspection. She is an authority of NMC inspection. I learnt a lot from her in 2 days. Yeah, no. Strict means she is very knowledgeable. Very nice to meet you, madam. After a very long time. Welcome, madam. Thank you, sir. Thank you, madam.
Thank you, ma'am, for such an insightful session. We can now appreciate the underlying forces that actually govern biochemical reactions and sustain life at a cellular level. Now I request our chairperson, Dr. Mahendran sir, to felicitate our speaker, Dr. S. Anu ma'am, with the memento. And I would also like to call upon Dr. Mrinalini, Head of Department of Obstetrics and Gynetics, to give certificate to our speaker.
Once again, I thank Dr. Prem sir for inviting me to chair this session, and my special thanks to Sudha madam and
we'll also request Dr. Celine ma'am. Thank you, ma'am. Thank you, sir. May I now invite Professor of Physiology, Dr. Shivagangai Lakshmi ma'am, to felicitate our respected chairperson, Dr. Mahendran sir, for their expert moderation. Please do the honors, ma'am. you, sir. Thank you, ma'am.
I'll stand there and I'll come from there. I won't stand here. Everybody know what it is.
And your big part portion.
Valedictory conclusion.
Half an hour से ज़्यादा.
ब्रेक हो गया, चल बैठ जा. बंद माइक बंद.
Moving forward to chair the next session on the topic of physiology of aging, we now invite Dr. Umarani ma'am, Associate Professor, Department of Anatomy at Government CUDDALORE Medical College. Ma'am brings with her 22 years of academic experience and mentorship. Please take honor, ma'am, to invite and introduce our speaker for this session.
Good morning, all. I am thanking you, madam, for inviting me as a chairperson for this session, Physiological Aging with the Physiological Changes with the Age. Now, I would like to invite Dr. Rekha ma'am, Professor and Head of the Department of Physiology, Dhanalakshmi Srinivasan, University, Samyapuram. Madam education is, she did her PG, MD Physiology in our prestigious Annamalai University, and PG Diploma in Diabetology from PSG Institute of Medical Science. CS, and also PG Diploma in Diabetology in our Annamalai University. She has 16 years of teaching experience in MBBS, Allied Health Science, Dental, Nursing and Physiotherapy, and also administrative roles including the Associate Dean and the Dean, a former Government Medical Consultant, She has been the PhD guide, examiner for multiple universities, had published 21 research publication, 1 patent. She has got one patent and guide for ICMR project. Now she received a recipient of Distinguished Service Award in 2023, life member of IMA and Association of Physiologists of India and Association of Physiologists of Tamilnadu. She is actively involved in conferences, CME programs and the faculty development. Thank you, ma'am.
Good afternoon. Thank you for the introduction. I am very happy to be here because I am 10th PG of this prestigious institute. I studied here during 10 to 13. I am very happy to serve as a faculty for this postgraduate integrated lecture series. 16 years back I was there when we attended in Vellore, CMC Vellore. We had our stalwarts of physiology, they were teaching us. Now I am here, I am really thankful for Sudha ma'am for inviting me. So I am going for the session. We are going to see about aging. One of the important thing, inevitable thing, irresistible thing, but it is happening for everyone. So the topic Anandha Thandavam 2026, it shows the harmony between the destruction and the renewal. So that is apt for my heading also. So I just put the picture. It symbolizes the eternal cycle of creation, how we preserve it, and how we prevent the destruction of aging of our system, bodily system. So main thing we are going to enlighten here, just do demon of the ignorance. We should ignore the factors of harming for our body. With this introduction, I am going for my topic. Physiological changes in aging. So picture itself depicts all these things mainly because of genetic material. There is a chromosomes. When we born, that time itself our time has been checked. From that time, aging starts in the chromosomes. Before going into it, as a PG students, you should know what are the specific learning objectives. At the end of the thing, you should know. First thing, how to define aging. Second, we are going to differentiate between the chronological aging and biological aging. Third, you have to describe the theories of aging. There are so many theories of aging, you have to know about it. And you can expect, I think, a 5-mark question about it. Depending upon the universities, it is between 5 to 7 marks. So these are the headings you have to cover. And you have to explain the cellular senescence and role of free radicals and antioxidant in it. Then finally, you have to discuss about the involvement of various systems in aging. These are the topics I am going to discuss with you. This picture itself shows aging. Can anyone tell what is a definition for aging? Aging, simple definition. So many things I itself told in the introduction itself. What is aging? It's nothing but it is nothing but a gradual deterioration of the physiological functions. It is inevitable and irreversible. What is the thing you heard? It increased the disease susceptibility and reduced survival rate of an individual. So we have to check the aging in order to have a living, happy living. Okay? In different countries, aging has been defined differently. In foreign countries, more than 65 years the term as elderly people, but in India, they term it as more than 60, they will call people as elderly people. Yes. What is the major difference between chronological aging and biological aging? What is chronological aging? It is nothing but how many years they have passed from the time of the birth. That is called as chronological aging. And biological aging differs functional ability of the individual and the system wise how they are function. This is the difference between the chronological aging and it cannot be the same. So what is chronological aging? It is age measured in years from the time of the birth, and it is fixed. It is the universal axis of the age, and easy to determine. One can easily determine the chronological age of the patient from the date of birth. Then it does not reflect the functional status of the systems. But this is not the same for the biological aging. It's mainly reflects the functional capacity of the organs and the system. Depending upon the functional ability of the individual organs and system, we can define the biological aging. It varies between the individual. Main factors for the determination of biological aging is genetic material. How the parents will be, how the grandparents, they will be reflecting their aging pattern. That is the main thing. And main thing nowadays contributing is lifestyle changes. How they are behaving themselves, how they change their lifestyles, how they are living, how they are eating. All the patterns changes. Even though genetic material is main thing, nowadays lifestyle changes plays a main role in aging. And nutrition. Why nutrition plays a main role in aging? Any guesses? Nowadays so many reels and YouTubes are going on for this only. What is the role of nutrition in aging? Whether it is macronutrient or micronutrient? Any PGs? PGs are always in the back and they are discussing. Yes, what is the major role of macronutrient in case of aging? One who consumes more amount of glucose, they will be having always, they will be exposed towards the insulin and they will be going for early acceleration of aging. That is the main concept of difference between diet and nutrition. Whoever consumes macronutrients more in terms of glucose, they will be having accelerated aging when compared to those who consume a composition, better composition or more amount of protein and fat. Okay, that is the main thing. Glucose leads to insulin and later they will be going for insulin resistance, accelerated aging. That is the main concept. And environmental factors also, exposure to various chemicals, availability of the drinking water, all these things contribute for the aging. And stress, it is also inevitable in this era. So you should avoid stress in order to have a healthy aging, graceful aging. So better indicator of health and aging is which one? Chronological aging or biological aging? Biological aging. So we are going to see about the theories of aging. So as a PG, you should know minimum 4 or 5 type of theories of aging going forward. That is, first is the evolutionary theory. That is mainly concentrating on the accumulation of the mutant materials. Whenever the mutation is getting accumulated over there, lately they will be becoming a harmful material for our cells to survive. So they will be leading towards the aging. They will be more accelerating toward the aging. And disposable soma. When the body prioritizes reproduction over long-term maintenance, they will also be going towards the process of aging. And antagonistic pleiotropic theory, genes beneficiary early. So first they will be looking like a beneficiary till age of 20 to 30. Later it will be becoming a harmful for our body and the body systems will be getting a aging process. And coming to the molecular theory, that is depend upon the gene regulation. What is the regulation of gene? The changes in the gene expression mainly affects the lifespan. So you have to mainly concentrate on the health of the genetic material. Whenever there is a change in it, so it will be going for the, even though the lifespan is increased, they will be having so many ill effects on the life cycle. Then codon restriction, these are the various things, errors in the mRNA translation. Main thing is error catastrophe, decline in the gene expression. Everything concentrate on the genetic material. And somatic mutations, so many mutations, DNA mutations mainly accumulated in the cells, they will be going forward the cell destruction and they will be leading towards the aging. And this differentiation, there is loss of proper gene regulation. So this molecular theory mainly concentrate on the gene regulation. Going to the third one, that is cellular theory. Any idea about which will be the most important thing as a PG? Whether the molecular or here the cellular? Cellular, because the important hero is there. What is there? What is the thing mainly contributing by the cellular senescence? Telomeres. So we will be discussing about it in the next slide. So telomere will be the limited cell division due to telomere shortening, and free radical theory, wear and tear mechanism, apoptosis. These are the main theories we need to concentrate in case of aging. And system based, it comes under neuroendocrine, immunological and rate of flaying. Whenever there is a dysregulation of hormones, it will lead to neuroendocrine aging, And whenever there is a reduction in the immunological function due to aging, mostly it will be reduction in the WBCs. They will be more suppressant towards the cancerous agents. They are more prone for cancers, and they will be more prone for immunoreactions, okay, abnormal immunoreactions, and the higher metabolism, shorter the lifespan. Anybody just disagreeing with me in the last point? Yesterday I was taking class for the UG students. One of the students just got up and asked, whenever there is a higher metabolism, they will tell the person will be very healthy, lean, and why you are telling they will be having less lifespan? Any point over there to conflict with me? So whenever somebody is having more amount of metabolism, the body heat, the temperature of the body will be increased. So thermoregulation is going in a negative way. So they will be more prone for aging. Even though the lifespan is increased, aging is accelerator in whomever getting a more number of metabolism, increase in body temperature, they are more prone for aging. This is the system-based thing. And this is the hero. What is telomere? Can anyone tell? What is telomere? What is telomerase? So many scientific discussions are going on in this. Can anyone tell what is this? This is telomere. What is this? This is a bow. What is there in your leg? You are tied with the shoe with shoelace. What is more important, whether the full shoelace or tip of the shoelace? You will be, just observe the shoelace tip, it will be protected by a plastic shield, okay? If that shield is damaged, you have to throw that shoelace and you have to buy a new thing. Like that chromosome has been defined, the tip of the chromosome is shielded by the telomere. It is nothing but a protective cap in the chromosome. It is protecting. Whenever cells go for divisions, it will be reduced in size. So depending upon the length of the telomere, not in the chromosome, the aging will be assessed. That is the main thing. So we have to mainly work on how to protect that telomere. What is telomerase? What is telomere? If there is a tug of war, what are the main things contribute for aging? As I told, lifestyle changes, hereditary changes, stress, environmental changes, everything will be on one side. Other side, what will be there? What is the main thing to balance aging in case of telomere? Telomerase will be there to compensate the loss by all these things. So you have to keep in mind, whenever aging is coming, you have to imagine, think about the telomere and telomerase. So you have to protect the chromosomal tip. This is about the thing I explained. So nothing but like a cap of the shoelaces, and we have a telomere for chromosome. This picture is very, very important. So its nature has defined it, we have copied it. That is the main thing. Nature correcta and chromosome helical pattern la senjirukku, we have copied it for the shoelaces. It prevents the chromosomes from deteriorating. This is the main thing about the telomeres. I encourage any of the new first year PGs, if you have any circumstances to research on aging, kindly take upon, at least do a review article for in telomeres. Okay? Yes. This is about it. Depending upon the length of the telomere, the aging will be assessed. When the infants or child or adult, the telomere length will be more. If the telomere is getting less and less, they will be becoming more old. That is the main thing. Why it is happening so? We have a Hay-Flick limitation. Can anyone tell what is Hay-Flick limitation? Because the source is only limited for the replication. If more number of replication has happened, it will be limited, it will be exhausted. That is the main thing for Hay-Flick limitation. Cells cannot divide, only a limited number of sources is available. If it is going so many replications, so it will go for exhaustion and they will go for aging. What is the role of, next thing we are moving on for ROS. What is ROS? Reactive oxygen species. What is the role of ROS in aging? Whenever there is a mitochondria, so when case of aging, we have to mainly concentrate on mitochondria and telomeres. Okay, those two are main important things in aging. One is the main source of energy, mitochondria. It also contributes for aging. Another one is for containing of material, genetic material, but it also contributes mainly for the aging. So mitochondria and ETC, the source of the cellular energy, they transfer the electrons, and whenever there is free radical production, depending upon it, the formation of reactive oxygen species will be there. They go for oxidative damage. They lead to oxidative damage mainly in the DNAs, mainly in the proteins. Proteins will be damaged. That is the main, and lipids also damaged. So it leads to overall cellular dysfunction. So depending upon the ROS, cellular dysfunction will happen, and it leads to the physiological aging. What happens in physiological aging? The cells will go for degeneration, tissues will go for degeneration, organs will go for degeneration. That is the main thing. How can we prevent it? This is about the antioxidant. Can anyone name antioxidant? What are the examples of antioxidant you know nowadays? Yes? Mainly about vitamin C, vitamin E. You should know the sources of all these things. Naturally, you can prevent the ROS. So these antioxidants, when it is applied, what it does? It mainly acts upon the free radicals. Vitamin C, vitamin E, and the plant polymer. What is CoQ10? Coenzyme Q10. This is also available. All these things, if it is consumed normally, it will be mainly acting upon the ROS, and it will prevent the aging process. How it prevents? It neutralizes the ROS mechanism, and it also scavenges the dead cells. Apoptosis. It naturally enhances apoptosis, and it will be scavenges this thing, and mainly prevents the cell membrane and cell function. Mainly the biomolecular damage will be prevented, cell lipid layer will be prevented, everything will be prevented. If at all damage happens, scavenging will be there. So ROS and oxidative, this antioxidant source should be in a balanced state to have a normal aging. The changes in the cells and the tissues. As I told, cellular changes will be reflected in the tissues, and collagen fibers become very stiff once the person started aging. So first the cells will be going for a degradation, then it will be reflected in the collagen fibers, it becomes stiff, and the elastin, it decreases. So collagen and elastin also changes. The hydrolysis of the elastin will be there, and the flexibility of the body decreases. That is the main complaint in aging they will tell about. We have to take care of the mobility of the elderly individual. So whenever the elastin and collagen fibers go for destruction, the mobility of the individual will be, flexibility, mobility will be decreased, along with the other changes. What are the other changes? These are the system-wise changes we are going to see. Includes all the system. What is the major system it involves? Central nervous system. Starting from that, it involves cardiovascular system, respiratory, all these things we are going to see. First thing, we will concentrate on the central nervous system. What are the changes we can expect? Structurally, it will be changing. So normally, the brain will be there, in adults it will be normal. What happens in elderly, whether it will go for shrinkage or it will go for enlargement. Few things it will go for atrophy also. We will see one by one. Okay. So structural changes, the mass of the brain, approximately 15% it will be reduced. Cortical atrophy will be there. So that is the main thing, it happens in the aging, and neuronal cells will be lost during aging as a wear and tear mechanism. And there will be a loss of synaptic neurons, or there will be a remodeling of the synaptic neurons. That is the main thing, signal processing will be delayed. And changes in the glial cells, supporting cell activity also will be lost. These are the major changes. And we will see the functional changes. Okay. In brain, cerebral metabolic rate will be reduced. So glucose utilization, it is the main fuel for brain activity. Utilization of the available glucose will be reduced, and cerebral blood flow also will be reduced, and neuronal plasticity. That is the main thing about the human brain activity. So in aging process, the neuronal plasticity will be reduced. So there will be a altered neurotransmitter signaling. All the signals will be altered. So there will not be a normal brain function. And degeneration of the dopaminergic neurons. What it leads to? Even the UGs can answer. What is the end result of the degeneration of the dopaminergic neurons? Yeah, very good. That is Parkinson. And what is the loss of cholinergic neurons leads to? This is one of the Alzheimer's. Whenever there is a reduction in the cholinergic neurons, it will lead to the memory function, that is Alzheimer's. Dopaminic neurons deterioration will lead to Parkinson's disease. These are the changes you can expect in the elderly people. And the other changes, there will be compensatory increase in the cerebrospinal fluid for the volume loss and deposition of, this is also a for memory loss. Okay, the cortex and hippocampus, deposition of the amyloid plaques. So clinically they will be presenting as cognitive decline with the aging. Whenever test for aging people for the cognition, there will be normally reduction in the cognitive function because of all these neurotransmitter and neuronal changes. This is the diagram which represents the changes between the adult and the senile persons, aged person. What is the main thing you have to concentrate here? There will be increased ventricular size. The left side is the normal adult brain, right side is the aged person's brain. And there will be increased ventricular volume. I told increase, there will be compensatory increase in the cerebrospinal fluid for the volume loss, and marked cortical thinning and sulci widening will be there. When compared to the adult brain, there will be cortical thinning and significant hippocampus shrinkage. What it affects? What is the role of hippocampus? Memory. What memory? It is the consolidation of memory will be there. Okay. Whenever there is going for hippocampal reduction, they will not be able to recall the things. Okay, that is the main thing. They will not be able to concentrate and consolidate. Marked cortical thinning and sulci widening will be there. Ventricles will be enlarged. These are the few changes we can expect between the brain of the adult and the aged people. When you go for the cardiovascular changes, what are the vascular changes you can expect in the elderly people? Mostly starting after, even after 20 years, the blood vessels, what is the main risk factor we have to look upon? Deposition of fatty material in the endothelium of the blood vessel that leads to atherosclerosis. This is the main thing we have to concentrate. And stiffness of the vessel wall will be there, and increase in the collagen deposition. There will be decreased in the elasticity. These are the important things you have to concentrate, because these are the main things contributing for hemodynamics in the cardiovascular system. And atherosclerotic changes, normally there will be, after 40 years, there will be increase in the systolic blood pressure. So there will be going for systolic hypertension. Okay. Then widen pulse pressure. What is the importance of pulse pressure? What is the importance of pulse pressure? What is the range of pulse pressure? All these things should be noted, because the pulse pressure is the main important for the perfusion to all the tissues. If it is widened, if it is not within the normal range, the perfusion towards the peripheral areas will be affected. So the systolic pressure will be increased, even though the diastolic is the variant for determine whether they have hypertension. Here in elderly people, normally the systolic blood pressure will be increased and the pulse pressure will be widened. And you can see the changes from between the normal artery and the aged thing. What is the main thing? Atherosclerotic artery, and it has become so stiff, it will be having plaques on the lumen, it is narrowed, and atherosclerotic plaque, mainly the calcified atherosclerotic plaque, and it becomes stiff. So all these things affecting the elderly people in the vascular system. This is the main thing in the vascular system. Coming to the cardiac thing, decrease in the number of the cardiac muscles, and there will be a deposition of a material called lipofuscin in the myocardium. So myocardium has to freely contract. This lipofuscin will be impairing it in the contraction, and thickening of the ventricular septum will be there. In aged people, normally ventricular septum will be thickened, and valves also, aortic and mitral valves will be thick. And mostly they will be having a left ventricular hypertrophy. That is the main thing. It shows us they are going for aging. Usually in aging they will be, and taller people, they will be also be having left ventricular hypertrophy. You have to just to think about it. And what are the functional changes you can expect? This is the main thing. There will be reduction in the force of contraction. So what will happen to the blood volume in the heart chambers? It will be accumulating more. That is the main reason for the left ventricular chamber hypertrophy. Then reduction in the resting heart rate will be there, and loss of pacemaker cells will be there. These are the functional changes, and few autonomic changes also will be there in aging. What are the autonomic changes? They will be having less number of baroreflexes. What is the importance of baroreflex in elderly people? What is the importance of baroreflex in normal people? They should have. What is baroreflex? regulation of the blood pressure, short-term regulation. So if there is a loss of reflex, they will go often tend to fall. Okay, then there will be reduction in the cardiac output altogether. So what they will present with, they will be presenting with systolic hypertension and reduced cardiac reserve. What is cardiac reserve? Can anyone tell? What is cardiac reserve? PGs? What is cardiac reserve? That is my first internal question asked by one of my faculty. What is cardiac reserve? Go and refer it. This is very, very important. One should have a reserve. இல்லையா வீட்லயே இப்போ நம்ம ஒர்க் பண்ணுறோன்னா கேஸ் இல்லைன்னா என்ன பண்ணிட்டோம் எல்லாரும் கேஸ் ரிசர்வ் பண்ணி வச்சிட்டோம். ஸோ ஒன் ஷுட் ஆஸ் லைக் cardiac, the heart will be having a reserve. Whenever we are going for training, athletic training or exercise training, our heart will be able to do more of work. That is called as cardiac reserve. And respiratory system, in structural, it will be having reduction in the chest wall compliance and increase in the lung compliance, loss of tissue elasticity. In elderly people, in respiration, the inspiration will be normal, but the expiration will be affected. So the recoiling ability will be lost. So more amount of air will be retained in the alveoli. The reserved volume of the air will be more in the elderly people. That is a change reflected. Vital capacity will be reduced. Residual volume will be increased because it is mainly affecting the expiration more than the inspiration. The total lung capacity remains unchanged. And what are the functional changes you can expect? Increase in the work of breathing. You can see many of the people will be more using the accessory muscles of respiration. Have you witnessed? They will not be having only the normal muscles of inspiration or expiration. They will be mostly using the accessory muscle of respiration. Work of breathing will be more. Impaired gas exchange will be there, and a decrease in the arterial partial pressure of oxygen and decrease in the efficiency of the respiratory sensing mechanisms. So all these things will be altered. How they clinically will be presenting? Reduced respiratory efficiency, and there will be reduction in the oxygenation in the tissues. Okay, already in the cardiovascular system, wide and pulse pressure. In respiratory system, they will be having reduction in the oxygenation to all the cells. Coming to the next main system, renal system. You all would have read in the renal system, the nephrons, yearly they will be going for reduction in the nephrons. So in aging, gradual loss of nephrons will be there. And in that, we have two types of nephron. What are the type of nephron? Cortical nephron, medullary nephron. What is the main function of the cortical nephron? What is the main function of the cortical nephron? What is the main function of the medullary nephron? The cortical nephron mainly concentration of the GFR, mainly for urine production. And what is the main function of the medullary nephron? It is mainly for concentration. So here in aging, normally the cortical nephrons will be affected first. So there will be reduction in the glomerular filtration rate. Then it goes for even the medullary nephrons will be affected, but first primarily the urine GFR will be affected, impairment of the counter-current metabolism as the medullary nephrons also getting affected. What are the functional changes? As I told, glomerular filtration rate will be reduced and tubular functions will all be reduced. What is the consequence of it? That we decrease the ability of the concentration of the urine. Then impaired excretion of the water. So elderly, mostly they will be having a mild amount of edema in the dependent parts, mainly due to all these things. Retention of water or the reduced excretion of water, electrolytes and waste products. So you have to mainly concentrate when prescribing normal drugs toward the elderly people, because you should not think these drugs will be eliminated, excreted normally. You have to concentrate upon the age also, then only you have to increase or decrease the dose accordingly. So what will be the clinical presentation? Increased risk of dehydration, and if they are on any drugs, the toxicity is more prevalent among the aged people. Coming to the endocrine system, main regulatory system of our body, general changes. Overall, there will be decline in the endocrine function. All the functions, endocrine functions will be reduced. There will be gross decrease in the hormone production and impaired maintenance of homeostasis. All the systems in our body contribute towards homeostasis. In that, central nervous system and endocrine system are the masters. Whenever the endocrine system go for aging, the homeostasis will be first affected. And coming to the metabolic changes, obviously the metabolism will be affected as the endocrine is involved. So basal metabolic rate of the body is normally in aging it will be reduced due to muscle mass. Muscle also lost. I will come to that later. And there will be reduction in the metabolic hormones. Thyroxine normally it will be reduced in the. What are the functional consequences in reduction in the endocrine system they will face? There will be impaired glucose homeostasis. That is the main thing. Whenever we talk about any of the thing current, we have to mainly concentrate on the glucose homeostasis. In aging, normally the glucose homeostasis will be affected and electrolyte imbalance will be there. What is the clinical associations? It will be having, mostly we can expect hypothyroidism, adrenal insufficiency and osteoporosis. Okay. What is the main role of hormones in osteoporosis? Calcium, magnesium, phosphate, all these things contribute toward the bone health. Coming to the main hero of it, gastrointestinal system. This is the root cause of all these. If you want to revert your aging or if you want to have a healthy aging, you have to mainly concentrate on the gut health, main thing. So whenever the motility mainly changes, is starting from the esophageal. First it will be, there will be reduction in the esophageal motility and reduction in the esophageal sphincter function also. They will be having more amount of GERD compliance, delayed gastric emptying and reduction in the colonic movement. They will be most often presenting with constipation. These are the main thing. Normally there will be reduction in all type of motility. And neuronal changes, reduction in the neurons in the plexus, mind plexus. So mainly it will be leading to reduction in the GI motility. They say they will not be having food as like adults. They will be cutting down the time of eating. Either they will be having 2 or 1, usually in the elderly. Because of the food they have consumed will not be getting digest as per the adult. And digestive and absorptive changes, there will be impaired digestion and impaired absorption. Why? What is the main thing we need for digestion and absorption? Villi. The villi, it will be more taller and more functional and more number of villi in adults. During aging, these villi will be, height will be reduced, the gap between the villi will be widened and the functional ability of the villi will be reduced. So all these things contribute towards the reduction in the absorption of the nutrient. Even though they are consuming more normal nutrients, it will not be getting utilized due to the normal aging changes in the GI. And intestinal will and altered taste sensation starts from the tongue and there will be reduction in the GI immunity. GI mainly contributes for the immunity, I think. These are the things I told. Villi, broad and they will be the reduced surface area. Surface area is more important. As like the saree, it is folded very much in the compact space. So the enlarged clips will be there and reduced surface area, goblet cells count will be reduced. All these things will be contributing towards the reduction in the absorption of the nutrients. Whenever the villi height is more, you can concentrate on the bottom. Whenever the height of the villi is normal, it helps in the absorption. In age, it will be shorter and even though it is atrophied. And in surface area, normally it will be there in adult. In age, it will be reduced, surface area. The nutrient absorption, normally it will be there. It will be impaired in age. These are the things contributed by the gastrointestinal tract. And coming to the completion of it, the liver size also will be reduced. And hepatic blood flow in the whole will be reduced. And liver function mostly it will be preserved. The size and the blood flow will be reduced. What will be the clinical correlation? They will be having increased susceptibility towards the GI disorders, motility disorders, nutritional deficiency disorders they will be presenting with. Dysbiosis, all these things will be there. Coming to the immune system. That is the general changes, there will be progressive decline in the immune function, affects both the innate immunity and adaptive immunity, mainly by the cellular changes. What happens in the bone marrow during aging? When we born, the red marrow will be more and the yellow marrow will be less. When we age progressively in our normal aging process, the red marrow will be replaced by the yellow marrow due to deposition of fat. So mostly the WBCs will be affected than the RBC and the platelets. So we have to mainly concentrate on the immune function of it. So normally WBCs will be less in elderly people, decreased production of T and B lymphocytes, decrease in the function of the mature lymphocyte, and the bactericidal activity of the WBCs also will be affected. So we have to be very careful in elderly people. They will be normal up to the age of 40 to 50, and they are more prone for the immunological reactions, autoimmune diseases after 40 and 50. What are the inflammatory changes? There will be increase in cytokine and chemokine levels in the elderly people. And what are the functional consequences? Reduce in the resistance towards the infection. Okay, if many of us are here, if one elderly people is there, if the WBC count is reduced, they will be more prone towards the infection. Even though we are able to defend it, they will not be having a resistance that much to resist the infection, and increased susceptibility of the cancers and immunodeficiency disorders. Autoimmune disorders are more common for the elderly people. There will be increased vulnerability to the infections, and consequences of it, they will be more prone for malignancies in elderly. What happens in the musculoskeletal system? ஒருத்தரை பார்த்த உடனே ஏஜாக இருக்காங்கன்னு சொல்லுவீங்களா? பார்த்தோன்னே சொல்ல முடியுமா? இல்லை உங்கள் வயசு என்னன்னு கேட்டுட்டு தான் சொல்ல முடியுமா? With the appearance itself, we can come to a conclusion whether they are young or not. Even at the age of 80 or 90, if they have a better muscle mass, bone mass and skin, good skin, they will not be called as elderly people. The main contributors of aging is muscle mass, bone mass and the skin texture. Okay, all these things should be preserved to have a healthy life. In this aging, normally there will be a progressive loss of skeletal muscle, that is called as sarcopenia. How to resolve sarcopenia? Can anyone tell? Yes, madam senji kamikiranga. That is strength training. What is that? Exercise is different, strength training is different. If you strength train your muscles, there will be decrease in the loss of muscles due to aging, and decrease in the muscle strength and functioning, and greater atrophy of the fast twitch fibers. I told you the strength will be, motility will be affected in aging, and fat, as like the bone marrow, fat also will be getting infiltrated in the muscle. What are the functional changes you can expect? Before going into that, this is the difference between the normal muscle and sarcopenic muscle. More the muscle, dense muscles are there, but it is getting atrophied, the loss of the muscle mass, and fat infiltration is there, and reduced in the cross-sectional area, and strength of the muscle is lost. These are the main things you can expect in the skeletal system. That's the muscular system also. These are the functional changes. They are getting old, they are getting lost their bones, and muscle is going for sarcopenia. The first thing they will be experiencing is reduction in the postural reflexes, reduction in the proprioception. What is proprioception? What is proprioception? Yeah, joint position in the space. They will be having the reduction in the proprioception, they will be having impaired coordination, and these are the major things one will be experiencing in the aging. So main thing, if you have any elderly people in your home or anybody more than 40, ask them to go for strength training in order to prevent all these things. Okay, we cannot change the aging, but we can gracefully age. And reduction in the bone mass will be there, and density will be lost. It leads to osteoporosis. So in skeletal muscular system, there will be sarcopenia and osteoporosis. These are the main things you have to concentrate. And what are the consequences in the musculoskeletal system? There will be reduction in the functional ability, reduction in the mobility, risk of falls are more. Whomsoever is there in your house will age, you have to be very careful with their movement in the restrooms. So avungalukku grip irukadhu, they are more fall for risk, and the bones are osteoporotic already, it can go for fractures. It will lead to immobility. These are the consequences of aging. So you have to mainly concentrate on the bone health, although risk of fractures. What is that? They will often come with fall and fractures in the elderly. These are the integumentary system. Epidermis and dermis will be thinned, reduction in the collagen and elastin fibers, skin elasticity last. Skin maintain பண்ணிக்கிட்டு bone muscle maintain பண்ணிக்கிட்டா age ஆனாலும் ஃபிட்டா நம்ம independent இருக்கலாம். That is the main thing we have to concentrate. What are the functional changes? Sweat gland activity will be reduced, sebaceous gland secretions will be reduced, skin hydration is lost first. That's why wrinkles happens in the skin. It gives a aged look. What are the pigmentary changes? Reduction in the melanocyte, and uneven pigmentation appears in all the skins, mainly in the face. And other changes we can expect as cutaneous, all system blood flow is affected, including cutaneous. And if at all any wound happens, there will be delayed in the wound healing. They will present with dry skin. Elderly அப்படினாவே first என்ன picture போடுவாங்க, dry wrinkled skin and impaired wound healing if at all. அங்கங்க wound இருக்கும், அது scar ஆனது, அதுதான் மெயினாக இருக்கும் elderly people. So these are the things we can prevent. What happens in the sensory system? Mainly in the vision in the ear. So eye lens என்ன ஆகும்? Usually accommodation will be lost. பெரியவங்க இருந்தால் பார்த்துருப்பீங்க, எங்கே வச்சு படிக்க வேண்டிய புக்கை எங்கே வச்சு படிப்பாங்க, கொஞ்சம் தள்ளி வச்சு படிச்சுட்டாங்கன்னா it shows that their accommodation is getting lost. Okay, presbyopic, they will go for it. Lens elasticity will be lost, pupil size will be lost, visual acuity will be reduced. So you have to take care of that. Hearing, there will be reduction in the high frequency sound perception and they go for presbyosis. That is age related hearing loss will be there in here. These are the main sensory system which we involved in. They will be presented with poor vision and poor hearing. And coming to the reproductive system, what happens in females? They will go for menopause and protective hormones will be reduced, and males lately but surely they will go for andropause also. The testosterone will also be reduced and the sperm quality will be reduced gradually when they age. And what happens in the hematologic? Already we have discussed, there will be reduction in the bone marrow, red to yellow, and RBC will not be much affected, platelet will not be affected. Main cell affected is WBCs. Coming to the disorders of aging, to finish with it, mainly for the PGs. If you are completing your question, you have to write with this. What is this? Hutchinson-Gilford progeria syndrome. Progeria எதில் பார்த்துருக்கீங்க, எந்த ஃபிலிமில் பார்த்துருக்கீங்க? Pa. It is a, yes, that is the main thing. Mutation in the lamin A gene, abnormal protein progerin will be there. Age lifespan, mostly it will be 13 years only. They will be having accelerated aging. Okay. At birth they will be appear normal, but in couple of years the somatic growth slows markedly, and clinical apparently they will be looked as aged people. And one more syndrome, that is Werner's syndrome. That is a late onset. It is very rare, 1 in 10 million only. The gene linked to chromosome 8, that is WRN gene. Senile cataract will be the main thing, and premature balding will be there. Loss of subcutaneous tissues. First என்ன ஆரம்பிக்கும், எல்லாம் தோல் எல்லாமே சுருங்கி போனோட ஒட்ட ஆரம்பிச்சிடும், subcutaneous tissues ஃபுல்லாக போக ஆரம்பிச்சிடும். Osteoporosis will be there. There is a high risk of malignancy in this syndrome. Okay, it will be diagnosed mostly in the middle age and they will die. These people will be having a better age when compared to the previous one. They will be having 50, but maximum is 50 only. They are high risk of cancers in these patients. And most of the elderly people are living with this. We have to take care of this. Alzheimer's, it is senile dementia. Mainly the cholinergic neurons will be going for normal degeneration, deposition of beta amyloid proteins, and diagnosis, taking care of these people is very, very important. What is the summary? Aging is gradual. It happens gradually only. In normally, it is inevitable. It is irreversible, but we can make it easy. Gracefully we can age. Involves multiple mechanisms from cellular level, molecular level, systemic, everything it involves. It is a physiological changes. It lead to decline in the functional capacity from the cellular molecular level to organ. It really leads to functional reduction in functional capacity, and reserves will be reduced, decreased ability towards response towards the stress, and increased vulnerability towards all sort of disease and infectious disease and cancerous disease. There is an increased risk of infection, chronic disease, falls and fractures. We have to take care of the elderly people. We have to take preventive measures. We have to provide a healthy aging for them. That is where we stand. Why we are talking about aging here. As a physiologist, you have to tell them how supportively they can age. What are the interventions you can provide in biological aging, not in the chronological aging? Diet, we can go for calorie restriction. As I told in the first, calorie, if it is we are providing with more amount of calories, it has to be getting digested, more amount of metabolism will be there, the body temperature will be more. In order to reduce the body temperature, we have to cut down the calories. So in order to prevent aging or have a good aging, you have to reduce the calorie intake as you age. After 30 or 40, you can go for what is IF. Nowadays so many Instagram, so many doctors, intermittent fasting. If you are reducing your time of periodicity of consumption, that is intermittent fasting, that will mainly decrease the insulin resistance. Many of us will be having insulin resistance. If we often go for fasting, that will reduce the insulin resistance, then make the insulin active. There is calorie restriction. And let's delay aging by having a good nutritionist diet. Avoid all these things, unwanted things. Do meditation, breathing exercises. Don't involve into the dirty politics. They are going to win, they are going to be there, they are going to gain. We are not going to have anything. If you want to vote, vote. Otherwise, don't go for the politics. That is the better thing we have for ourselves. And go involve in physical activity. If you are aging more than 30 or 40, better go for strength training. Not only exercise will help you, do strength training. Don't take any kind of stress. முன்னாடி சேதுபதி சார் சொன்னாங்க, என்ன நடந்தாலும் சரி ஸ்ட்ரெஸ்ஸே எடுத்துக்க வேண்டாம். யூ ஹாவ் டு பி ஹாப்பிலி லிவ். உங்கள் லைஃப் உங்களுக்காக மட்டும்தான். டோன்ட் கெட் இன்வால்வ் இன் எனி கைண்ட் ஆஃப் ஸ்ட்ரெஸ். கோ ஃபார் யோகா அண்ட் ஹாவ் அ ஹெல்த்தி ஏஜிங். Age is inevitable, but healthy aging is achievable. These are my references. Along with guidance, I have gone for ChatGPT, AI tools for the educational purpose. Thanks for this opportunity. Thank you.
Thank you, ma'am. You elaborate the lecture in every system in a detailed manner. Thank you, ma'am. Any questions, any clarification? Any questions, any clarification? You ask madam. No questions? No queries? No need of any clarification? Okay, with this we conclude the session. Thank you, madam.
I would request the physiology PGs who are being delegates here to receive this handout given by Celine madam. Next session.
Thank you, ma'am, for that enlightening session of physiology of aging. It really helped our delegates to appreciate how human body evolves over time and how every change reflects the intricate balance of life. To conclude this session, may I now request our chairperson, Dr. Umarani ma'am, to felicitate our speaker, Dr. K. Rekha ma'am, with a memento. Please do the honors, ma'am.
Thank you so much, ma'am. Now I respectfully invite our organizing secretary, Professor Professor Dr. Manisundaram sir, to felicitate our chairperson, Dr. Umarani ma'am.
Thank you, sir.
So I thank Rekha for her wonderful presentation. She was not well. Yesterday only she sent the presentation, and really I am very much happy to be with us here. Thank you.
Thank you, ma'am. It is now my distinct honor to introduce our next chairperson for the next session of this symposium, Dr. Shivagangai Lakshmi ma'am. Professor of Physiology at Government CUDDALORE Medical College. With a remarkable career spanning 36 years of selfless service, she has shaped the lives of countless professionals. Ma'am, we most respectfully invite you to grace the podium and also invite and introduce our next speaker who will be taking the session on topic respiratory physiology.
First of all, I thank for this opportunity. I would like to introduce our next speaker, Dr. D. Celine, Madam, Professor and Head of the Department of Physiology, Chengalpattu Medical College. She finished her MBBS in MMC, MD Physiology in Stanley and DCH in Stanley. She has got over 30 years in government, 30 years of government service, including 24 years of UG and 18 plus years of PG teaching, with 4 years of rural medical service. And her academic achievements are: she is the former editor of National Journal of Physiology, reviewer for M.G.R University Journal, and resource person for CMEs and postgraduate teaching programs. Regarding her research and publications, she has published 15 publications, and she has got special interest in neurophysiology, metabolic disorders, exercise physiology, and autonomic functions, and published so much related publications in that. So I welcome ma'am for the lecture, please.
Good afternoon all. Good afternoon. First and foremost, I thank God for making me part of this wonderful teaching learning session. I thank Dr. Sudha and her team for giving me this opportunity. எத்தனை physiology PGs இருக்கீங்க? சரி, அந்த ஹேண்ட் அவுட்டில் கொஷின் ஆன்சர் கேட்டிருக்கேன், அதெல்லாம் படிச்சுட்டு நீங்கள் எழுதணும்னு கிடையாது, சரியா? 7 பேப்பர் கொடுத்துருக்காங்க, மேடம் டெஸ்ட் வச்சுட்டாங்கன்னு நினச்சிக்காதீங்க. ஜஸ்ட் ஐ வாண்டட் யூ டு நோட் டவுன் த பாயிண்ட்ஸ் ஆஸ் ஐ எம் டேக்கிங், தட்ஸ் இட். ஓகே, இல்லைன்னா ஏற்கனவே லஞ்ச் டைம். லாஸ்ட் ஸ்லைட், வாட் வாஸ் த லாஸ்ட் ஸ்லைட் ஆஃப் மேடம்ஸ் ப்ரெசன்டேஷன்? வாட் ஆர் ஆல் த திங்ஸ் யூ ஷுட் டூ டு ப்ரிவெண்ட் ஏஜிங்? அதில் ஒன்று கூட நம்ம பண்ண மாட்டோம். எஸ் ஆர் நோ? ஃபஸ்ட்டு என்ன போட்டிருந்தாங்க? ஹெல்தி டயட். இன்றைக்கி என்ன மேடம் லஞ்சு? நிறைய சாப்பாடு, நல்லா சாப்பிடணும். நேற்று நைட்டு எத்தனை பேர் நல்ல ஒரு கட்டு கட்டுனீங்க டின்னர்? நேற்று நைட்டு. மத்தியானம் நீங்கள் கொடுத்தது மாத்திரம்தான் சாப்பிட முடியும், நைட்டு வந்து அப்படி கிடையாது, அப்படி தானே? ஸோ ஆல் ஆஃப் யூ சிட் எரெக்ட். Take a deep inspiration, hold, expiration, inspire, expire, inspiration, expiration, inspiration, deep inspiration பண்ணும்போது எப்படி பண்ணோம்? எஸ், ஆனால் எப்படி பண்ணணும்? எப்படி பண்ணணும்? when we take a deep inspiration என்ன ஆகணும்? வெளில வரணும். ஆனால் நம்ம எப்படி எடுக்கிறோம்? are we breathing the right way? அதே தப்பு. முதல்ல ஃபஸ்ட்டு பாயிண்ட்டே அவுட்டு. நினச்சி பாருங்கள், ஜஸ்ட் சிட்ட இப்போ செஞ்சு பாரு. டீப் இன்ஸ்பிரேஷன் என்ன ஆகணும்? வெளில வரணும். எக்ஸ்பிரேஷன், ஆனால் நம்ம என்ன பண்ணுறோம்? ஸோ வித் திஸ் ஐ ஸ்டார்ட். என்னோட செஷன் வந்து 3:15 to 4:40 அந்த மாதிரி இருந்தது, அதனால் குட் ஈவினிங் ஸ்லைட் போட்டேன். ஸோ வாட் வி ப்ரீத் is from the atmospheric air we take in. So when it reaches the alveoli, what change has happened? What change has happened? Humidification. By humidification, the partial pressure of oxygen is decreased. Partial pressure of carbon dioxide is also decreased, right? So which is advantageous? At the level of the alveoli. Oxygenation, you're having decreased oxygen for entering into the capillaries, but with respect to carbon dioxide, the concentration is less and you have plenty of carbon dioxide can diffuse out in the reverse direction. Yes? So what is this? How is the lung? How is the thoracic cage? What is forming the thoracic cage? Pinadi enna irukku? Vertebra. முன்னாடி என்ன இருக்கு? ஸ்டர்னம். ரெண்டுக்கு நடுவில் என்ன இருக்கு? ரிப். ரிப் எப்படி இருக்கு? இப்படி வளைச்சு பிடிச்சி பின்னாடி ஒரு அட்டாச்மெண்ட், முன்னாடி ஒரு அட்டாச்மெண்ட். எஸ். ஸோ வாட் இஸ் த டெண்டன்சி ஆஃப் த thoracic cage? Always it wants to move out. What is the nature of your lung? It is a elastic bag. What is its tendency? It is always tending to collapse. So one is trying to collapse, one is trying to moving out. These two structures are held close to each other. That's what is given here. Okay. So what is happening? The lung is having a tendency to collapse. The thoracic cage is having a tendency to move out. And these two forces, these two opposing forces are balanced at one particular state. What is that state? At which volume or capacity both the centrifugal and the centripetal force is neutralized and the lung is said to be at the resting state. Which volume or capacity you achieve this? Which volume or capacity? FRC. What is FRC? Hari answer பண்ணக்கூடாது. Hari பிரேம்லாம் வாயை திறக்கக்கூடாது. What is FRC? Functional residual capacity. At what phase of your respiration this is achieved? FRC contains what volumes? Oi. Rendu volume ennalla? Residual volume and expiratory reserve volume. So FRC is achieved at which phase of respiration? End of expiration. So end of expiration is the neutral state for the lung where the opposing forces balance each other. Okay, it is from the FRC we take a tidal volume of inspiration followed by expiration. So all the tidal volume, your routine normal respiration is just 500 ml above FRC. That's it. Only that much we do when we are in the resting state. Okay. So at FRC, the elastic recoil of the lung and the chest wall balance each other. What is this? In the pakka enna irukku? Absolute pressures, relative pressures. What do you understand by this? What is 760? Normal atmospheric pressure. You call at, when we talk about the lung wall, lung pressures, the alveolar pressure, the intrapleural pressure, we always talk of the intrapleural pressure as a negative pressure. It is -10, -5, -2.5. So it is in the apex -10 and at the base it is -2.5. By that we mean that the pressure is 758. It is less by -2 from the atmospheric pressure. So when we talk of -2.5, the absolute pressure in the intrapleural space is 757.5. Okay, when we talk of -10, it is around 750. Is it clear? So we talk of something as intra-alveolar pressure as 0, -1 and +1. What does it mean? It is equal to the atmospheric pressure, negative with respect to atmospheric pressure and positive with respect to atmospheric pressure. So what is transpulmonary pressure? Transpulmonary or trans lung pressure அப்படினா என்ன அர்த்தம்? The pressure that is operating on either side of the lung tissue. That is How you arrive at that? Intra alveolar pressure minus intra-pleural pressure. So it will be a negative or a positive pressure? Transpulmonary pressure. It's a positive pressure. It's +4. Transmural pressure across the chest wall. Abdina? Across the chest wall means between the intrapleural pressure and the atmospheric pressure. Is it clear? What is the intrapleural pressure? It's minus something. Atmospheric pressure is plus something. So minus of minus. So the transmural pressure across the chest wall will be the pleural minus the atmospheric pressure. The transmural pressure across the respiratory system will be the sum of the pressure across the lung and the chest wall. That is transpulmonary pressure and the mural pressure across the chest wall. When we sum these two, you arrive at the trans pressure across the respiratory system. So give reasons for the difference in intrapleural pressure or pressure in the intrapleural space from apex to base. இதுக்கு என்ன reason இருக்கும்? Lung, how it is, does it have any attachment? Lung. Apex la enna attachment, base la enna attachment. You have some ligament at the apex and some ligament at the base, right? Yes? What is that ligament? Do we have something? Is there any ligament to fix the lung? Except for the hilum, there is no attachment, so it is just floating inside the intrathoracic space. So as it is floating, when we stand, because of gravity and because of this posture, the lung descends down. When we lie down, it is at the equal. When we lie down on the right, it is moving to the right and the left side has more space. When we move to the left, the opposite is happening. Why the alveoli are not uniform diameter? எல்லாத்துக்கும் ஒரே ரீசன் தான் வரும். அதுக்காக தான் எல்லா क्वेश्चनயும் ஒண்ணா போட்டுருக்கேன். Give reasons for the linear increase in blood flow from the apex to the base. இது மூணுக்குமே கிட்டத்தட்ட ஒரே மாதிரி தான் ஆன்சர் வரும். Okay. So what is the reason? It is mainly அதுக்கு தான் பேப்பர் கொடுத்தேன், ஃபோட்டோ பிடிக்கிறதுக்கு இல்லை. I'll share the PPT with you all. It will be posted in the group. You need not take any photos. Okay, I'll share. It will be in the group. Whatever you understand, you try to write down. நீங்கள் எழுதுறது தான் உங்களுக்கு புரியும். 2 நாள் கழிச்சு இது ரெண்டையும் பார்த்தா கிராவிட்டி எதுக்கு சொன்னாங்க, ஐயோ ஞாபகம் இல்லையே அப்படி வரும். சரியா? So whatever you understand, write down in your own terms. So gravity and posture is the reason for almost all these things. So what is this? West zone. West zone na another. The difference in the perfusion at the apex and the base. Why is there a difference? Again, because of the effect of gravity, because of the position of the heart and the lung, there is a difference in the flow of blood across the lung. There is also a difference in the stretchability of the alveoli. Where is the negative pleural pressure maximum? It is in the apex. So what will happen to the alveoli in the apex? It will be in the dilated state. It is more compliant. It is very much dilated. Yes? Yes or no? It is very much distended. So what will happen to this distended alveoli when you have a normal respiration? With normal respiratory cycle, you have an alveoli in the apex which is well distended. You have an alveoli in the base and the middle zone which is partially distended. You are taking a inspiration and expiration. Air or the ventilation, how much is the alveolar ventilation? It is tidal volume minus what is alveolar ventilation? Dead space. What is dead space volume? Whatever is in the non-exchange area is the dead space volume. So out of this 350 ml, this 350 ml is going to get diluted with the FRC volume. Yes? FRC volume is the volume that is present in the lung when at the end of normal expiration. Over that you are taking at idle volume. 150 ml of that is in the dead zone, it is wasted. Rest will enter into the alveoli. I am asking, you have some alveoli which are distended in the apex, some alveoli in the base. Which will receive more ventilation, the apical alveoli or the basal alveoli? Yes. மேலையா கீழையா? மேலையா கீழையா? மேலே எத்தனை பேர்? இப்போ பக்கத்தில் இருக்கவங்களாம் கீழே. எஸ், யார் கரெக்டு? கீழே தான் கரெக்டு. மேலே இருக்கிறது என்ன ஆகும்னா டியூரிங் இன்ஸ்பிரேஷனுக்கு முன்னாடியே அது டிஸ்டெண்டடாக இருக்குது. எஸ், இட் இஸ் டிஸ்டெண்டட் அட் ஈவன் அட் த எக்ஸ்பிரேட்டரி ஃபேஸ். ஸோ இதுக்கப்புறம் இதுக்கு மேலே டிஸ்டெண்ட் ஆகாது. So, amount of ventilation entering into the apical lobes will be comparatively less. The percentage of air that is moving in and out from the apical alveoli will be comparatively less when you talk about the middle and the basal alveoli. So, anga அப்படியே இருக்கும். Perfusion எப்படி இருக்கு apexல? How is the perfusion? Perfusion is less. No perfusion at all both in the systolic and diastolic phase? Yes? Yes? No. There is no part of the lung which does not receive any perfusion both in the systolic and the diastolic phase. So during systole there will be blood flow. During diastole there is no blood flow when you talk of perfusion in the apical zone. Okay. So there will be little gas exchange only. Always the ventilated, the distended alveoli will have comparatively higher oxygen saturation because there is less perfusion. So there is not much exchange, so the oxygen saturation will be comparatively more in the apical lobe. That is one of the reason for something else. What is that? I'll tell you. So the apical alveoli are distended, the middle and the lower zone, the alveoli are less distended. That has reached its maximum, it is very difficult to stretch that beyond that volume. This can change its volume with change in pressure. So ventilation is better in these two zones. Okay. Why tuberculosis is more common in the apical lobes? More oxygen. One. Second point, less perfusion. So when there is less perfusion, what else will happen? The amount of WBCs that is entering into that zone will be very less. The amount of immune system activity is comparatively less. Immune clearance is less. Again, the lymphatic flow is less. So all these factors will contribute to more preponderance to tuberculosis in the apical lobe. Reactivation tuberculosis is also common there only. Yes? யாராவது எக்ஸசைஸ் பண்ணுறோமா? யாராவது இப்படி விரட்டினா மாத்திரம் தான் ஓடுவோம், இல்லைன்னா comfortably sitting. Yes? What will happen to your system when you are exercising? What does this graph tell? மேலே இருக்கிறது என்னது? Arterial PCO2. கீழே இருக்கிறது என்னது? Alveolar ventilation. So this is 0 is start of exercise. What is the reason for increased ventilation with exercise? What happens to your partial pressure of oxygen and carbon dioxide with exercise? Carbon dioxide increases. Carbon dioxide is a potent stimulator of ventilation. So when you exercise, ventilation is increased because carbon dioxide is more. Your statement is wrong. At the start of exercise, your ventilation has increased. Your ventilation has increased at the start of exercise itself. Even before you start doing your exercise, as you think and as you start your exercise, your ventilation has increased. See what is happening to the partial pressure of carbon dioxide? It is decreased. So carbon dioxide accumulation is not the cause for ventilation in exercise. Have this in mind. Carbon dioxide nala எப்போவுமே என்ன பண்ணோம், carbon dioxide is a potent stimulator for ventilation. Yes, not oxygen. But when you exercise, it is not the partial pressure of carbon dioxide which is creating the alveolar ventilation to increase. It is something else. Because the Guyton graph da. Okay, exercise ஆரம்பிக்கும் போதே ventilation has increased, and at the start of exercise your partial pressure of carbon dioxide is decreased, and as you exercise you generate carbon dioxide, and a ventilatory rate is already increased, and you are able to dispose of the carbon dioxide, maintaining the partial pressure of carbon dioxide at the normal level. Is it clear? Exercise பண்ணும்போது carbon dioxide நால ventilation increase ஆகல, ventilation ஏற்கனவே increase ஆனதுனால extra carbon dioxide is washed out, and you are able to maintain your carbon dioxide saturation. ரெஸ்ட்ல ஹைப்பர் வென்டிலேட் பண்ணால் என்ன ஆகும்? சும்மா உட்காந்துட்டு எத்தனை பேர் பிஜிஸ் எம்விவி பண்ணியிருக்கீங்க ஸ்டடியில்? 12 seconds and you calculate it for 1 minute. என்ன ஆகும்? When you hyperventilate, how you feel? மயக்கம் வந்துடும். Hyperventilation will cause metabolic alkalosis. Okay, so hyperventilation la first ஆரம்பிச்சிருது எக்ஸசைஸில். This is going to maintain a carbon dioxide concentration at the normal level when you are exercising. At the end of exercise, the ventilation comes back to the normal state, the carbon dioxide concentration increases, and this will cause a second increase in ventilation. Exercise முடிச்ச உடனே அப்படி கப்புன்னு நார்மலுக்கு வந்துடுறோமா? கொஞ்ச நேரம் மூச்சு வாங்கிட்டே இருக்கும், even after exercise. So initial phase is because of something else that is centrally mediated. There is impulses coming from the cortex to increase your ventilation. The mechanoreceptors will be stimulated, which also will cause an effect on the medullary center to increase the ventilation. What is this? When you exercise, the alveolar ventilation is at a higher level to maintain the partial pressure of carbon dioxide within normal limits. Okay. So at exercise, the respiratory rate increases before the start of exercise, activated by neural stimulus and the mechanoreceptors. Increase in rate is proportional to carbon dioxide accumulation எப்போதான்? At the end of exercise, not at the start of exercise. This is flow volume loop, you all know, yes? How is the inspiratory curve? How is the expiratory curve? இது எப்படி இருக்கு? அழகாக சட்டி மாதிரி ஸ்மூத்தாக இருக்குது. மேலே இருக்கிறது எப்படி இருக்கு? ஒரு பீக், அப்புறம் கட கட கடான்னு குறைஞ்சிருக்கு. ஆனால் வால்யூம், இஸ் தேர் எனி டிஃப்ரென்ஸ் இன் த வால்யூம்? Inspiratory capacity and expiratory capacity, will there be any difference? Not much difference, very minimal difference. The same volume is blown out, yes, but the curve is smooth here, the curve is not smooth there. What will be the curve in a normal quiet respiration? அப்பமும் கீழே இப்படி மேலே பீக் வருமா? ஒரு நிமிஷம். This is tidal volume curve. Just see. Smoother curve. Both inspiratory curve and expiratory curve is smooth. But forced inspiration and forced expiration, the curves are not similar, even though the volume is similar. Why is this difference? ஏன் இந்த டிஃப்ரென்ஸ் இருக்குது? எல்லாருக்கும் பசிக்க ஆரம்பிச்சிச்சு, தூங்குறாங்க. எனிபடி? Inspiration, forceful inspiration is because of what? Your resting inspiration, tidal volume inspiration is because of what? Your diaphragm and the expiratory intercostal muscle. Forced inspiration, this will work more number of fibers are recruited. Yes, so it is the same active process which is again increased by the number of fiber recruitment, and few accessory muscles are also recruited to increase the volume. How this is achieved? When you start an inspiration, what is the first thing to happen? Inspiration pannanuna first thing another. It's a nervous signal. Then contraction of the muscle. The thoracic cage is expanding. The intrapleural space, the volume is increasing. The pressure falls. Once the pressure falls, the lung is moving along with it. The alveolar pressure falls below that of the atmospheric pressure, air is sucked in. Yes, this is the cycle. So during forceful inspiration, the same is done in a forceful way. There is increase in the alveolar space, the airways are expanding, the resistance is less, there is smooth entry of air. Okay, so the inspiratory curve is always smooth. But when you do an expiration, what is happening? Normal expiration is passive. The inspiratory muscles just leave, just cease to contract. Everything goes back to the normal state. But forceful expiration, you forcefully do the expiration. When you forcefully do the expiration, what's happening to the intrapleural space pressure? It becomes positive. It is compressing on the lung. The airways are beginning to narrow down. Before that happens, before the airways are getting narrowed, there is a gush of air out into the through the nostrils, and this is what we are through the mouth, and this is what we are recording. So the amount of force you exert will decide the amount of output of air. But as you push more and more air out, what happens? The volume decreases, more pressure is there, the airways are getting narrowed, the resistance is increasing, air is not able to move out. So the volume decreases slowly. And in the last phase, it is only the elastic recoil which will decide how much of air is going to move out, and no way the force is going to affect the output. Okay. So inspiratory flow curve is decided by the strength of the inspiratory muscle and the intrapleural pressure. More negative the pressure is more because of more strength of the muscle that is contracting, and the recoil pressure of the lung is increasing. Romba stretch pannona enna recoil pressure is increasing, and this is going to oppose the expansion. And airway caliber is increasing, this is going to decrease the resistance, this is going to favor the air entry. So there are two favoring factors and only one opposing factor, namely the elastic recoil of the lung. But when you do expiration, the effort will decide the amount of air that is moving out in the initial segment. Later what happens, if you increase the effort, if you increase the force, this will cause collapse of the airways. So the air is not going to move out. Okay. That's the reason why the slow vital capacity and forced vital capacities are different. So the flow volume loop has a effort dependent part and an effort independent part. The minimal effort independent part will be the same how much ever you give the force. But the effort dependent part will be varied depending upon the force you give doing expiration. That's why when you are doing the vital capacity maneuver, you have to do it carefully. Make sure the person is giving the exact force, maximum force that person can achieve. இல்லைனா உன் வேல்யூஸ் தப்பாக வரும். ஒருத்தர் பண்ணும்போது ஒரு மாதிரி வரும். ஓகே. So when the pressure is increased, what happens if you are going to exert more and more pressure, the airways will collapse, that will lead to air trapping. This is what is happening in all the obstructive lung diseases. So initial peak expiratory flow is effort dependent, and 50 to 75 or the FEF 75 or the mid airway volume is effort independent. So there is something called as equal pressure point. What is this? Equal pressure point another. During expiration, what is happening? Air is moving from the alveoli to the larger airways through the upper respiratory tract out. Yes? So there should be a pressure gradient. Pressure should be maximum in the alveoli. Slowly it should be decreased. Then only it will be moving out. And the pressure gradient irundha da air velila vara mudiyum. Okay. What is happening to the thoracic pressure, intrathoracic pressure? During expiration, it's becoming less negative. So it is trying to compress. Okay. So the airways should have a pressure more than that of this external pressure. If the airway pressure is less than this external pressure, the airways will collapse. If it is more, then air will flow. This compression will favor airway to push the air out. So in a normal person, this equal pressure point, the point at which the intraluminal pressure and the external pressure is equal, will be in the upper airways, will be in the larger bronchioles, will be at the level of trachea or the branching bronchi. Here you have cartilage. So even if the external pressure compresses, this cartilage will resist the obstruction and you are able to maintain the airway, air can flow out. In a diseased person, in patients with emphysema, in patients with chronic obstructive lung disease, this equal pressure point is moving down. It's moving into the smaller airways. So what happens when the pressure is more outside, the intraluminal pressure is comparatively less, then it will compress the airways. The equal pressure point is lower down. There is no cartilage to support the airways. The airways collapse, leading on to air trapping. அதனால தான் obstructive lung disorderல air trapping இருக்கு. In bronchial asthma, inspiration and expiration, which is difficult? Expiration is difficult. Why? அப்பதான் airways எல்லாம் narrow ஆகும். எப்போ sound கேட்கும்? Wheeze. Expiration. Okay, there is difficulty for outflow. There is a noise, there is turbulence. Okay. Equal pressure point is the point during expiration where the intraluminal pressure is equal to the intrapleural pressure. Okay. In normal lung, it is in the upper larger airways. In COPD, the elastic recoil is lost. EPP is in the smaller airways, so there is air trapping. அதே தான் இதுலயும். So what is the role of abdominal breathing and pursed lip breathing in emphysema? Is it useful or not? When we try, what is happening in emphysema? What is happening to the total lung capacity? There is air trapping, there is increased residual volume, there is increased functional residual capacity. The lung is, you have a barrel shaped chest, the diaphragm is flattened. So when the diaphragm is in the flat position, it is not able to contract effectively to generate a pressure to increase your inspiration. So when you do an abdominal breathing, when you are doing an abdominal breathing with an expiration, when you try to expire with the abdominal muscles, you are forcing the diaphragm to move up. The residual volume decreases, the functional residual volume capacity decreases. So next cycle, the inspiration, more air can enter. Okay. So this is one important point. The second point is when you try with pursed lip breathing, what happens? It increases the pressure in the airway. So the equal pressure point, which is in the lower airways, will move to the upper airways. So there is little of air trap. That's the reason why emphysema is benefited by these two maneuvers, or increasing the peak expiratory pressure. So abdominal breathing is slow controlled expiration, increases the effective ventilation, and also it decreases the work of breathing. it increases the expiratory time. So prolonged expiration, all the air can move out, the residual volume is decreased comparatively. Pursed lip breathing will increase the pressure inside the airway. It is something like your PEEP. It moves the equal pressure point from the lower airways to the upper airways, preventing the air trapping. So why cough causes decreased venous return? One important function of negative intrapleural pressure is your respiration, apro venous return, thoracic pump. So whenever the intrapleural pressure is becoming positive and stays positive for a longer time, what happens to the venous return? Venous return will decrease, cardiac output will decrease, blood flow is decreased, the person is presenting with syncopal attacks. Okay. So inspiratory phase, increase in tidal volume. Compression phase, there is increase in the intrathoracic pressure. Exactly, it is this point when the venous return is going to decrease. And expiratory phase, you give a cough and you push out the content out. Okay. So it decreases the venous return, decreases the cardiac output. There is syncopal attack. This is more common in patients with COPD and obesity. So when there is cough, there is decreased venous return, arterial hypotension. This arterial hypotension will decrease the cerebral blood flow, leading on to syncopal attacks. So why patients on ACE inhibitor will present with cough? Any idea? What is the function of ACE inhibitor? Angiotensin converting enzyme. Where it is used? Hypertension. It is used to decrease the blood pressure. Can it be used in renal hypertension? Hypertension dana. It will cause juxtaglomerular apparatus la onu padipom nyamba irukka afferent arteriolar constriction, efferent arteriolar dilatation. So angiotensin 2 is going to increase the renal blood flow, increase the GFR. If you are blocking this with ACE inhibitors, the renal GFR will decrease, it will aggravate the renal hypertension. Okay. So similarly here what happens, bradykinin is inactivated by the angiotensin converting enzyme. So whenever you block this enzyme, this bradykinin concentration will increase, it will irritate the nerve fibers, it will cause cough. Okay. So bradykinin is inhibited, it is not metabolized whenever you use an ACE inhibitor. Okay. So the person will present with cough. What is the role of basophils in the pulmonary circulation? It's good or bad? Basophils. Pulmonary circulation, it's more. எங்கள் பிஜிஸ்லாம் சிரிக்கிறாங்க, எதையே கேள்வி எத்தனை வாட்டி கேட்டுகிட்டே இருப்பாங்க அந்த மேடம். What does it have? ஒன்று inflammation, it is the cause of inflammation. Okay, அது விடுங்க. Next, heparin. What is the role of heparin in basophils? What is the role of heparin in basophils in pulmonary circulation? Pulmonary circulation is acting like a filter. Lot of microthrombi, microclots will be entering into the pulmonary circulation. It's already a slow circulation. So chances of these clots getting occluded is more, and clots can build up also. The larger thrombi also can be formed. This heparin released by the basophils will be very important in lysing all these things. Okay. In allergy, eosinophil count is also high. It's good or bad? Eosinophil is a cause or effect of allergy? இப்போ எனக்கு வந்து பேசோஃபில் கவுண்ட் ஹையாக இருக்குது, யூஸ்னோஃபில் கவுண்ட் கம்மியாக இருக்குது. பிரேம்க்கு வந்து பேசோஃபில் குறைஞ்சிருச்சு, யூஸ்னோஃபில் ஹையாக இருக்குது. நாங்கள் ரெண்டு பேரில் யார் சேஃபாக இருக்கா? நானா? நானா இல்லை, பிரேம் தான் சேஃப். Eosinophil will have histaminase. Histaminase will lyse the histamine. Eosinophil recruitment in a pulmonary circulation means your body is working. The immune system is working to try to correct the inflammation created by basophil. Okay, eosinophil count high இருந்துச்சுன்னா நல்லது தான். ஆனால் எப்போ பிரச்சனை ஆகுது? ட்ராபிக்கல் யூஸ்னோஃபிலியால் என்ன ஆகுது? This eosinophil recruitment is increased more than what is necessary. தேவைக்கு அதிகமாக வருது. அப்போ என்ன பண்ணுது? இன்ஃப்ளமேஷனை அது ட்ரிகர் பண்ணுது. Okay, normally the effect of eosinophil in pulmonary circulation is to clear the allergy created by basophil. ஆனால் இப்போ என்ன ஆகிடுது? ஹைப்பர் ஆக்டிவ் இம்யூன் சிஸ்டம் மாதிரி ஆகிடுறதுனால we present with complications. Okay, so give reason. இதெல்லாம் உங்களுக்கு நல்லா தெரியும். நைட்ரஜன் நார்கோசிஸ் ஏன் வருது? partial pressure as you go down increases. Partial pressure of nitrogen increases. Nitrogen is lipid soluble. It goes and binds to the lipid content of the cell membrane is more, it is in the central nervous system. அங்கே ஃபுல்லாக போய் என்ன பண்ணிடும்? பிளாக் பண்ணிடும். The transmission across is not there. Nitrogen narcosis occurs when you ascend up from the depth. Yes? Yes? தூங்குறீங்க. நைட்ரஜன் நார்கோசிஸும் பென்ஸ் டிசீஸும் டிஸ்பாரிசமும் சினானிம்ஸா? வேறையா? வேறு என்ன வேறு? Joint pain is dysbarism, joint pain is Ben's disease. அது எப்போ வரும்? கீழே இருந்து மேலே வரும்போது தான் வரும். இது நைட்ரஜன் நார்கோசிஸ் எப்போ வரும்? உள்ளே இருக்கும்போது வரும். இதையும் அதையும் குழப்பக்கூடாது. யூஜி குழப்பலாம், பிஜி குழப்பக்கூடாது. கீழே இருக்கும்போது நைட்ரஜன் கண்டென்ட் ஜாஸ்தி ஆகிறதுனால லிப்பிட் மெம்ப்ரெயின்ஸ் எங்கே ஜாஸ்தியாக இருக்குது? சென்ட்ரல் நர்வஸ் சிஸ்டமில். சென்ட்ரல் நர்வஸ் சிஸ்டமில் கண்டக்ஷன் எல்லாம் குறைஞ்சி போயிடுது. மந்தமாயிடுற, போதையில் இருக்க, மயக்கமாக இருக்க. தட் இஸ் நைட்ரஜன் நார்கோசிஸ். மேலே வரும்போது திஸ் நைட்ரஜன் இஸ் கெட்டிங் ரிலீஸ்ட், bubbles are formed, nitrogen bubble embolism is there, the person presents with Ben's disease. Both are different. Okay. So it's different from Ben's disease. It's not the same. எத்தனை பேர் டைவ் அடிப்பீங்க? டைவ் அடித்தா என்ன ஆகும்? டண்டனக்கா டனக்குனாக்கா. ஏன்? டைவ் தானே அடிக்கிறோம். இந்த டண்டனக்கா டனக்குனாக்கா கீழே போகும்போது நடக்குமா, மேலே வரும்போது நடக்குமா? மேலே வரும்போது நடக்கும். வை? டைவ் பண்ணுறதுக்கு முன்னாடி பார்த்துருக்கீங்களா என்ன பண்ணுவாங்க? நல்லா மூச்சு விடுவாங்க. மூச்சு விட்டால் என்ன ஆகும்? ஹைப்பர் வென்டிலேட் பண்ணால் என்ன ஆகும்? ஏற்கனவே என்ன படித்தோம்? கார்பன் டை ஆக்சைடெலாம் வெளில போயிடும். அதுக்கப்புறம் என்ன பண்ணுவோம்? டைவ் பண்ணும்போது நல்லா மூச்சு விட்டுக்கிட்டே டைவ் பண்ணுவோமா? பிரெத் ஹோல்ட் பண்ணிடுவோம். எஸ், கார்பன் டை ஆக்சைடை வெளில தள்ளியாச்சு, பிரெத்தை ஹோல்ட் பண்ணியாச்சு, உள்ளே போகிறோம். மெட்டபாலிசம் பாட்டுக்கு நடந்துகிட்ருக்கோம், பிரெத் ஹோல்டு பண்ணியிருக்கோம், ஆக்சிஜன் எல்லாம் யூஸ் ஆகி முடிஞ்சிடும், ஹைபாக்சியாக போயிடும். கார்பன் டை ஆக்சைடு தேவைக்கு அதிகமாக வெளில தள்ளிட்டோம். ஸோ கார்பன் டை ஆக்சைடு இஸ் நாட் கோயிங் டு ஸ்டிமுலேட் நவ். ஓகே, ஸோ என்னாகும்? ஹைபாக்சியா வில் காஸ் செரிப்ரல் செல்ஸ் டு பி இன்ஆக்டிவ், ரெஸ்பிரேஷனே குறைஞ்சிரும், பர்சன் வில் டை. சில சமயம் கார்பன் டை ஆக்சைடு பில்டப் ஆகும், ஏன்னா மெட்டபாலிசம் நடந்துகிட்டே இருக்குது. பில்டப் ஆனால் என்ன ஆகும்? பிரேக்கிங் பாயிண்ட். யூ கேன் நாட் ஹோல்ட் யுவர் பிரெத். எஸ், பிரேக்கிங் பாயிண்ட். யூ ஸ்டார்ட் ரெஸ்பிரேஷன். தண்ணிக்குள்ளே ரெஸ்பிரேஷன் பண்ணால் என்ன ஆகும்? தண்ணி உள்ளே போயிடும். ஸோ எப்படினாலும் என்ன ஆகுது? டண்டனக்கா டனக்குனக்கா தான். ஓகே, அண்ட் இட் இஸ் ஹேப்பனிங் இன் அ வெல் ட்ரெயின்ட் பர்சன், சடன். நாட் இன் ஆல், பட் திஸ் ஆல்சோ இஸ் ஹேப்பனிங். So one is because of decreased oxygen. If carbon dioxide is going to get accumulated and try to protect you, it is going to cause breathing or ventilation to be stimulated, you cannot breathe inside the water. So air is entering into the airways and you are going to die. Epdiyo. Pure oxygen, it's good. Oxygen dane. Nalla breathe panla. No. Why? Oxygen will release free radicals. There is a system to combat this. Oxygen free radicals ellathiyum destroy panna. We have an antioxidant system in our body. When this antioxidant system cannot handle the excess oxygen free radicals which is produced, then the person will present with toxicity. Okay. So it oxidizes polyunsaturated fatty acids of the cell membrane, oxidizes the cellular enzymes, and this also causes brain dysfunction. Helium oxygen mixture, why we are using? Airway resistance, when it is increased, it is going to increase the work of breathing. Helium is of a low density, so the airway resistance will be less, the work of breathing will be less. You are able to maintain your oxygenation, you are able to do better work with less amount of respiration, less amount of respiratory metabolism, so that the person can stay a little longer in the depth. Both restrictive and obstructive disorders decreases ventilation, true or false? Obstruction la ventilation, that is your vital capacity is decreased or not? Both obstruction and restriction, vital capacity is decreased or not? Decreased. Why? Restriction epallam varum? Restrictive disorders epallam varum? First lernd vaanga. Nervous signal illa appadina muscle contract agadu. Adukaprom muscle weakness, your thoracic cage is not going to expand. Then something wrong with the thoracic cage, restriction. Something wrong with the pleural space, restriction. Something wrong with the pleura, restriction. Something wrong with the alveoli, something wrong with the interstitium, restriction. Either outside to inside or inside to outside. Okay. When the lung is less compliant, you are not able to take more air, you are not able to push out more air, your vital capacity is less. What's happening in obstruction? Obstruction, you are able to take, but already your FRC is high because of air trapping, long standing obstruction. Already the FRC is high, above that you are going to take, and when you blow out, I have already told, obstruction is going to be exaggerated when you increase your force of expiration. So air trapping will be there, again the vital capacity is going to be less. So both restriction and obstruction, vital capacity is going to be less, but which will be the indicator now? FEV1 will be less in obstruction, FEV1 will be more in restriction. Is it clear? So restriction, either neuromuscular disorder, chest wall, something wrong with the pleura, something wrong with the parenchyma and interstitium. Work of breathing is more rapid, shallow breathing. FEV1 is normal or maybe increased. In obstruction, foreign body aspiration, bronchitis, mucus secretion, edema or smooth muscle constriction, emphysema, alveolar valve damage is the reason. Increase in static compliance with increased inspiration. Dynamic compliance will be altered in emphysema. It is the static compliance will be normal, but the dynamic compliance will be less. Surfactant keeps the lung dry. Why? இதெல்லாம் உங்களுக்கு தெரிஞ்ச question தான். What is surfactant? Surface tension reducing agent. Surface tension is there in the alveoli. When the tension is more there, it will try to pull the fluid. When surfactant is there, it is going to decrease the pressure. Fluid movement from the capillaries inside is not going to be there. Again, the pulmonary circulation is a low resistance circulation. The hydrostatic pressure is less compared with the oncotic pressure. So it is trying to hold the fluid inside. If at all fluid enters into the interstitium, the lymphatic system is very well developed in the pulmonary circulation. This lymphatic system will take away what has escaped. So always the lung will be dry. So normally surface tension tries to pull water inside. Surfactant reduce fluid accumulation. It prevents collapse of the alveoli. Pulmonary circulation is a low pressure circulation. There is effective lymphatic drainage, which also will favor the fluid getting accumulated within the pulmonary circulation. Compliance என்னது எவ்வளோ ஈஸியாக நம்மளால் ஸ்ட்ரெச் பண்ண முடியும். காம்ப்ளையன்ஸ் இஸ் மோர் அப்படின்னா என்னது? அபெக்ஸில் எப்படி இருக்கும்? மோர். அப்போ அது குட்டு தானே. ஆனால் நான் குட் இல்லைன்னு சொல்லி கொடுத்தேன்ல. ஏன் குட் இல்லை? எலாஸ்டிக் ரீகாயில் கம்மி. காம்ப்ளையன்ஸ் இஸ் குட். ஆனால் என்ன பண்ணோம்? முடிச்ச உடனே திரும்ப சுருங்கணும். இது சுருங்கவே மாட்டேங்குது. ஓகே, ஸோ இது எல்லாருக்கும் தெரிஞ்ச கர்வ் தான். இன்ஸ்பிரேட்டரி கர்வ் and expiratory curve is not going to be the same, but these two curves are close to each other in the initial phase and the end. Why? First ஆரம்பிக்கும் போது என்ன சொல்வோம்? Alveoli are collapsed. You require more pressure to open up this alveoli. Once it is opened, gada 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 நேரும். அதே மாதிரி மேலே போன அப்புறம் என்ன ஆகிடும்? மேக்ஸிமம் காம்ப்ளையன்ஸ் ரீச் ஆகிடுச்சு. அதுக்கு மேலே ஸ்ட்ரெச் பண்ண முடியாது. It is becoming less compliant. Here it is less compliant. There it's less compliant. There மேக்ஸிமமாக விரிஞ்சு முடிஞ்சிருச்சு. இங்கே ஓப்பன் பண்ணுறதுக்கே நிறைய ப்ரெஷர் வேணும். ஓகே, ஸோ ஸ்டேஜ் 1 no change in volume with change in pressure. Stage 2 opening of airway, the lung volume will increase. Stage 3 நல்லா அழகாக கடகடன் இன்க்ரீஸ் ஆகணும், ஏன்னா நிறைய ஓப்பன் ஆகிடுச்சு. Stage 4 it has reached its maximum, it cannot be distended beyond that. It is static compliance. Okay, for a given transpulmonary pressure, the primary cause of hysteresis is surfactant. அது உங்களுக்கு தெரியும் அந்த procedure. Surfactant enlarged alveoli la surfactant is distributed more, the surface tension is little more. In a small alveoli, surfactant is closer, the surface tension is less. Okay, for a given transpulmonary pressure, the lung volume is more during expiration than inspiration. That means இங்கே இருக்கிறத இவ்வளோ பெருசாக ஆக்கணுங்கும்போது எக்ஸ்பிரேட்டரி ஃபேஸில் இருக்கிற அல்வியோலையை ஸ்ட்ரெச் பண்ணுறதுக்கு கொஞ்சம் ப்ரெஷர் போதும். இன்ஸ்பிரேட்டரி ஃபேஸில் இருக்கிற அல்வியோலையை ஸ்ட்ரெச் பண்ணுறதுக்கு நிறைய ப்ரெஷர் வேணும். ஓகே, சர்ஃபேஸ் டென்ஷன் ஃபார் அ கிவன் வால்யூம் இஸ் மோர் டியூரிங் இன்ஸ்பிரேஷன் அண்ட் எக்ஸ்பிரேஷன். தெர் இஸ் இன்டர்டிபெண்டன்ஸ் ஆஃப் அல்வியோலை. ஒரு அல்வியோலை விரியும் போது என்னாகும்? பக்கத்தில் 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 எல்லாத்தையும் இழுக்கும். தட்ஸ் த ரீசன் ஃபார் த லீனியன் இன்க்ரீஸ் இன் த compliance curve. Okay, so இதுதான் நான் ஏற்கனவே எக்ஸ்பிளைன் பண்ணது. Foreign body aspiration always in the right lung because anatomy. Okay, residual volume is more in obstructive disorder. Why? Air trapping, and the equal pressure point is lower down, so there is more air trapping. Flattened diaphragm, எது கேட்டாலும் இந்த பாயிண்ட் எழுதினா போகிறோம். Dynamic compliance, this also I have explained. Acute pulmonary edema and acute cerebral edema in high altitude. Why? ரெண்டும் hypoxia தான். ரெண்டுக்கும் hypoxia தான். Pulmonary circulation, what is the effect of hypoxia? Yeah. All through the body, what is the effect of hypoxia? Vasodilatation. Pulmonary circulation, it is vasoconstriction. Once there is vasoconstriction, this blood is going to be diverted into other areas. So there is a mixture of a lung with areas of vasoconstriction, areas of vasodilatation. In areas of vasodilatation, the hydrostatic pressure is going to increase. There is going to be fluid getting out from the circulation. There is pulmonary edema. When you talk of cerebral circulation, hypoxia causes vasodilatation, increased hydrostatic pressure, movement of fluid out, cerebral edema. Okay. bronchial asthma treatment வச்சு reason out கேட்பாங்க. Why sympathomimetic is used? What is the effect of sympathomimetic on lung? Somatic வந்து skeletal muscle க்கு போயிடுது. Autonomicல you have sympathetic and parasympathetic. Sympathetic is going to cause bronchodilation, decreased blood flow, decreased secretion. Parasympathetic is going to cause bronchoconstriction, increased blood flow, increased secretion. What is the neurotransmitter in the sympathetic nerves? Norepinephrine. Epinephrine இருக்கா? இல்ல. Epinephrine எப்போ வரும்? Sympathetic adrenal gland லேந்து தான் வரும். So nervous innervation of lung is less with the sympathetic nerve, more with the parasympathetic nerve. That's why the person presents with bronchoconstriction. ஏதாவது ஒரு சின்ன trigger bronchoconstriction போயிடும். Okay. But when the sympathetic system is getting activated, when the adrenal medulla is releasing the catecholamines, the norepinephrine, epinephrine both are getting released into the circulation. Epinephrine is a very potent bronchodilate. So sympathetic innervation is minimal. Epinephrine and norepinephrine acts through beta receptors. Epinephrine, the dilatation is going to be stronger with epinephrine. You use salbutamol, which is a sympathomimetic drug, and this in turn is going to cause palpitation because it's also going to stimulate the beta receptors in the heart. So idhila epdinalum combination kekkalam reason out. Okay. Why you are going to use atropine in the treatment of bronchial asthma? It is a parasympathetic blocker. So it is going to decrease the bronchoconstriction mediated by your parasympathetic nerves. Respiratory changes in pregnancy. What happens in pregnancy? All ligaments are relaxed. So thoracic cage at the end of second trimester and third trimester, the diaphragm is going to push. Adukku munnadi varaikum thoracic cage is going to be getting expanded. That's one thing. Second thing is, because of your progesterone and estrogen, it causes increase in the secretions and the epipar or nasal congestion, always some upper respiratory tract in our inflammation ode irpanga early stages of pregnancy. That is because of the hormones. Okay. So I have just tried to complete, and I know nariya irukku. I have not touched upon oxygen transport adella. I have not touched upon regulation of respiration. அதுக்கு இன்னொரு 1 hour கொடுக்கணும், பெல் அடிச்சிட்டாங்க. Okay, I think I have explained at least over 20%. If you have any doubts, you can get it clarified.
Thank you very much, ma'am, for the detailed explanation given by you in this session. You have covered almost all the topics that are important for the reasoning out questions in the respiratory system, so that I hope our PGs will be benefited much by this session, ma'am. Thank you very much, ma'am. Now the session is open for the questions, or any queries are there, you can ask. Doubts can be cleared, will be cleared by ma'am.
There will be no doubt if you don't understand anything, and if your understanding is very clear also, there will be no doubt. நான் வந்து செகண்ட் ஆஸ்பெக்டே எடுத்துக்கிறேன், அப்போ தான் எனக்கு ஹாப்பியாக.
Reka, you told during diving,
first they will be doing voluntary hyperventilation, then they will be having a cessation. How to maintain it, ma'am?
Actually, this is not happening in all the individuals, and this is happening only in very few percentage of the persons, and the reason, these are the two proposed reason they are giving. You cannot prevent it at all. It happens. Very rare, but 2 to 3% only it happens.
Thank you, ma'am. Thank you. Any other questions, doubts? Okay, now we will conclude the session, ma'am. Thank you very much.
Okay,
Thank you, ma'am, for such an engaging session. We all can now appreciate the elegance of every breath and intricate mechanism that sustain life. We are really grateful, ma'am.
To conclude our session, may I now request our esteemed chairperson, Dr. Shivagangai Lakshmi ma'am, to felicitate our speaker, Dr. D. Silin ma'am. Please do the honors, ma'am. I would also now request our organizing chairman, Professor Dr. Sudha ma'am, to felicitate our respected chairperson. Please do the honors, ma'am. Now it's time for lunch. I would now request all the delegates to proceed for lunch. It's on the second floor in the physiology department. And you all should be back by 2 p.m. here itself, and then we'll proceed with our last session for today.
Class won't do anything. Joshua. Joshua.
Welcome back, everybody. Hope everybody had a heartfelt meal. It's now my pleasure to welcome our next chairperson, Dr. Shivagangai Lakshmi Ma'am, Professor of Physiology at Government Cuddalore Medical College. Representing a distinguished legacy of 36 years in the field of medical education, Ma'am brings a wealth of knowledge and steadfast commitment to medical teaching. We invite you to the podium, Ma'am, to lead this session and introduce our speaker, Dr. Vikramadityan sir, for his talk on the neuroscientific perspective of Anandha Thandava, decoding sacred geography and neurodynamics through Lord Nataraja. Due to unavoidable work commitments, sir is unable to grace us with the presence, so it will be a video lecture. Over to you, ma'am.
Okay. I would like to introduce the next speaker, Dr. Vikramadityan, MD. Professor of Medical Sciences, Ajman University of Science and Technology, Gulf Medical University, UAE. Education-wise, he graduated MBBS from MMC, MD from RMC, and PG Diploma in Annamalai University. And regarding the academic achievements, he is the recipient of international awards, including a gold medal for enlightened leadership, recognized for contributions to holistic medicine, research, and global health initiatives. And coming to his experiences, he is an international director, Global Union of Scientists for Peace, Senior Academy Fellow, International Entrepreneurship Academy, Medical Sciences Professor, Ajman University of Science and Technology, Gulf Medical University, UAE, and medical colleges in India. And regarding his expertise, expertise in holistic health, lifestyle disease management, medical teaching, research, and developing consciousness-based management programs. We will see the video of the speaker, Vikram Adityan sir.
Vanakkam, Namaste to the most respected dignitaries, my elderly teachers, friends and students of life. Welcoming you to this symposium, the lecture series on integrated physiology. I am humbled to present before you the neuroscientific perspective of Anandha Thandava, decoding sacred geography and neurodynamics through Lord Nataraja. This is part of a great series of discoveries of the millennium, blessed to the world by His Holiness Maharishi Mahesh Yogi, the representative in recent times of the eternal Vedic tradition of masters. with thanks to the greatest discovery in recent times, that is the discovery that human physiology is an expression of Veda and the Vedic literature. This has come to the world through Dr. Tony Nader, MD, PhD, who received his MD degree from the American University of Beirut, where he studied internal medicine and psychiatry. He received his PhD in the area of brain and cognitive science from the Massachusetts Institute of Technology. And Dr. Nader was a clinical and research fellow in neurology at the Massachusetts General Hospital, Harvard Medical School, USA. And his interest in the full potential of human mind led him to the practice of transcendental meditation. And he soon began working closely with Maharishi Mahesh Yogi, who guided him to this amazing discovery that the entire human physiology is actually structured on the sound vibrations generated by the Vedic literature. And this brought him to be the successor of Maharishi's global movement. And due to this discovery, we were facilitated and inspired by Maharishi's continued knowledge to discover the principles of Vedas that structures the geography of the world. So this discovery of correlation that I received between the ancient pilgrim centers of the world and the human nervous system was absolutely possible only because of this world transforming discovery of association between human physiology, which was found to be an expression of Veda and the Vedic literature. Let's now dive directly into the topic of how we can decode the association of sacred geography of Chidambaram with the neurodynamics of Lord Nataraja. Well, in the whole world, the Nataraja idol, the sacred posture of the cross-legged Nataraja, is very unique to Chidambaram. Though this kind of iconography and sculptures are present in all the other temples, Saivite temples, especially Shiva temples, everyone since eternity knows that the Nataraja cosmic dance is unique to Chidambaram. Now, before we go into understanding the major discovery that I had mentioned, which was inspired again by Maharishi Mahesh Yogi ji and the disciple Dr. Tony Nader, who correlated the Vedas with physiology. And what I received as a blessing was how I could now correlate the physiology with the Vishwa, or the world. So it's a beautiful dance of microcosm and macrocosm. So the microcosmic is absolutely related to the macrocosmic, and that revelation was inspired by the repeated assertions of Maharishi Mahesh Yogi ji, who used to tell that the cosmic switchboard of the world is India. The Indian sacred space holds the key to the world and the collective consciousness of all the nations. It was really unbelievable, like when I hit upon this idea. But purely by God's grace, I could decipher and decode everything associated with the ancient temples and how they precisely matched with the neurological centers in the brainstem. That was the initial part. So here we are going to again see that in particular, this was a major point in the series of discoveries that I was blessed with over the years. Nataraja cross-legged posture matched exactly with the pyramidal track decussation. And not alone that, all the mythological stories associated with this temple began to be deciphered in sequence, and it was so physiological that I couldn't miss it. So let's again go back to the original discovery and how I could associate and bring to light that Bharat, in fact it started from the South India, how it matched with the brainstem. In this slide, you can see the pyramidal tracts marked in the red color in the animation, which is revolving around. And this is to show that the pyramids, which are towards the anterior surface of the brainstem, and the pyramidal tract, which we have correlated with the Chidambaram sacred zone, which is in the east of India. So the ventral portion of the brainstem correlates with the eastern part of the land of Bharat or India. This is a gross analogy, and then when we go deeper, we see that in the north-south axis, again the correlation is perfect, as the fibers from the cortex, that's the pyramidal tract, descends down, and this descent is also called path or pata in Sanskrit, falling down. That is again from the north the Maharishi Patanjali descends down like the pyramidal tract, and where it crosses is really interesting to see in the subsequent slides, matching exactly with the sacred zone of Chidambaram. Discovery of the association between Lord Nataraja at Chidambaram and the pyramidal decussation is originally part of the grand unifying discovery of the millennium, that is the discovery of correlation between human nervous system, the sacred pilgrim sites, and cosmic bodies. This presentation explores an interdisciplinary hypothesis that the iconography of Nataraja, particularly the Anandha Thandava, that is the dance of bliss, reflects underlying neurophysiological principles. By integrating neuroanatomy, brainstem physiology, and sacred geography, the study proposes that Indian subcontinent symbolically maps onto the human brainstem, with special emphasis on the pyramidal decussation as the pivotal crossing point of motor and integrative pathways. And the sacred mythology associated with Chidambaram perfectly fits on to the neurophysiologic principles that are evident today in this modern world by the modern scientific explorations. As part of the introductions to the foundations of the discovery of correlation between ancient pilgrim sites of the world and the human nervous system along with the cosmic bodies, it's absolutely essential that we understand that Rig Veda has been associated with the holistic functioning of the physiology by Dr. Tony Nader. Well, the syllables, verses, stanzas, and mandalas of Rig Veda have been mapped in the entire structure of the nervous system and in all the peripheral nerves controlling the activities of the tissues, organs, and organ systems. The basic theme of organization of Rig Veda has also been located within the DNA of every cell of the body. This discovery of Veda in the physiology makes the study and knowledge of physiology a study and understanding of Veda. In our search for understanding the cause of the situations, let's explore the meaning of Shiva. The Devata that administers silence is called Shiva, and the Devata that administers dynamism is Vishnu. Linga is a symbol of the entire brain. This is an understanding that can help us correlate the brain and the geographically activated sacred sites. Consciousness and brainstem. It's been deciphered very clearly that the seat of consciousness is not spread widely as thought before. The thalamocortical complex does not seem to be critically essential for consciousness experience, whereas the brainstem mechanisms by its own can create adequate consciousness state. This means that consciousness without a cerebral cortex is possible. Penfield and Jasper note that a cortical removal, even as radical as hemispherectomy, deprived their patients certainly of information and discriminative capacities, but not consciousness. The Maharshi's knowledge of human physiology and its correlation to Vishwa, which came out in 2007, is again seen here in clear terms as how the brainstem correlates to the geography of Bharat. In our continued efforts to understand how the human nervous system is actually projected onto the geography of our world, we can see this superimposition analogy of the human head exactly getting superimposed over the Asia, and how the medulla oblongata gets superimposed over the Indian subcontinent. And this analogy is just not based on shape, but primarily we understand that the timeless concentration of active pilgrim sites in the whole world is maximum in India, and the living traditions of Bharat, of this eternal laws, are ever vibrant in our culture. This discovery explains why India has always been the leader of nations And of course, there are ups and downs in civilization when, because of forgetfulness of the grandeur and the responsibilities that we were blessed with, when we forget that, we descend to new lows and then rise up again to our birthright and our responsibilities, so that the whole world can be balanced through the active pilgrim centers that we have in Bharat. In this slide, we will explore why we have to take the left sagittal section of the brain, or the sagittal section of the left brain. Why? Because we all know that since eternity, the nature has been divided, or we can say viewed with two angles, that is the Purusha and the Prakriti. And always the masculine aspect has been associated with the right side and the feminine with the left side. This is the cultural perspective that has been passed on to us since ages. Now, the Bhumi, or the Bhuma Devi, we have been introduced to as regards Mother Earth, will be the exact correlate of the left brain, because left, we know, is Prakriti, or the feminine principle. That is why we take the left sagittal section, or the sagittal section of the left lobe of the brain. And this actually correlates not alone with the shape, but all the neurological centers get a complete meaningfulness over ancient sacred spots when we superimpose this aspect of the brain. India's, or Bharat's, knowledge is knowledge of consciousness. Outside India, the education is to train the expression of consciousness, which is physiology, or our body. Physiology is the expression of consciousness. Vedic knowledge is always to handle consciousness. Non-Vedic knowledge, that is the knowledge outside of India, is to handle the expression of the consciousness, that is the physiology or the body. So either remain with the expression of consciousness, which is the effect, or you handle the cause, which is consciousness. Atma. Atmai Vedam Sarvam. This is the exhortation of Vedic knowledge, exhortation of Vedic action, exhortation of Vedic reality, which puts knowledge and action together. Yogastha Kuru Karmani. Established in the state of unity, perform action. This is India. India means dealing with the cause, dealing with consciousness, Chetana, which is equal to consciousness. Bharat ka Vigyan, Chetana Vigyan hai. Science of India is science of consciousness. It's the eternal Dharma, Sanatan Dharma. These were the words of Maharishi Mahesh Yogi Ji, spoken on May 15th, 2003. In this slide, as per the guidance of Maharishi, Tony Nader could associate the correlation of 27 lunar constellations with the 27 monoaminergic groups of neurons that are clustered in the brainstem. And this discovery, again, is something absolutely fascinating, because every nuclei that modern science has mapped in the brainstem has its exact correlate with the nakshatras, or the constellation patterns in terms of structure and function. And it's really unbelievable discovery that the time has brought about. One needs to look at the depth of this discovery to understand what is the cosmic reality that we are living in at this particular point of time. That we are so blessed to be in this sacred zone of Chidambaram, because it gives us the power, it gives us the complete responsibility to alter the functions of different geographic places, because we happen to be at present in charge of the collective consciousness of the world through the powerful sacred space in Chidambaram. Now we will be seeing how Patanjali Maharishi is associated with Chidambaram in a physiological perspective. Now we see that the Yoga Sutras of Maharishi Patanjali have been completely associated with the association fibers of the cerebral cortex. What this means is actually Professor Tony Nader has been highly successful in correlating the 195 aphorisms or the sutras with the 195 gyri in the cerebral cortex. Now this is a fascinating discovery which you will see in the next slide, and then we can cognize that the fibers from the gyri, which descends in the tract called pyramidal tract, comes down caudally, and in the lower medulla it crosses to the opposite side. And this is where the Chidambaram is correlated in the neurological correlate map of the world. This is very fascinating because the mythology completely and totally gets synced with physiological realities. Now let's witness graphically the cross-legged posture and the pyramidal decussation unfolding before us. Another important point that you can notice that the association fibers, which has been correlated with Patanjali Yoga Sutras, by the name itself means union. Association is nothing but union, and we all know that yoga or yog is that yoking of the individual soul with the cosmic soul. So multi-level correlations has been always the standpoint from which new discoveries are made. So here also we are finding that the pyramidal decussation is the point that is most important in the physiological functioning of the brainstem, because the left-right dimensional shift is very important for balance and integration of our perception in the physical world, which is 3D, to the 2D projection of the fibers. So it's really a beautiful neurological reality that unfolds before us, and now we have another dimension of the geography also getting correlated, confirming that the microcosm and the macrocosm is always related. In our efforts to confirm the actual correlation between neurological structures in our physiology with geographical ancient pilgrim sites, let's take up one more correlational project. That is, let's venture into geophysiological relationship correlation between Chidambaram Nataraja temple and Thiruvidai Mardur Mahalinga Swami temple. This is again a wonderful facet that we have, because in the whole world we have one major temple that has been specifically marked as Mahalinga. It's not just Linga, it's Mahalinga. And we know that Maha means great. And what is great? Like a cricketer, if he's going to bang century, and then another cricketer comes and hits out a double century, then we call that guy as a Maha guy, the greater one. So doubling up. So here also there should be a depth of meaning in Mahalinga. That is, the Mahalinga Swami temple in Thiruvidai Mardur should be having something double than other lingas, and we will also decipher that in detail. It's so interesting because we can understand that all the mythological stories, all the pointers, every small detail that we have with us in this sacred geography of Tamilnadu is absolute neuroscience. Nothing has been just named for the heck of it. Everything carries meaning, only that we have been blind to that. We have been mistaking that we are assumed to be special, and we are we have been thinking ourselves great, and we are the most superstitious. All these kind of perspectives that we had as Indians have to give way, and now we should establish ourselves in the reality of neuroscience. All our ancestors have been great neuroscientists and great people. Of course, we agree that there has been some letdowns because of which we lost this art, we lost the science of life. And now, thanks to modern medicine, thanks to the other half of the world, which developed so much that they can help us regain our culture, regain our balance, and regain our vision to appreciate the truth, appreciate the wonderful blessings that we have had since eternity. Let's focus now on the prefix Maha. Why the Linga at Thiruvidai Mardur is called as Mahalinga. This is a simple derivation because we know the brain is considered as a linga. We saw in the preceding section that Professor Tony Nader has given a complete explanation as to how the linga is nothing but the replica of brain. And of course, in quantum science, Professor Dr. John Hagelin and many other quantum physicists have brought out the linga ellipsoid shape and curve to represent silence and the great science behind linga. Now, the presiding deity in Thiruvidai Mardur temple is Mahalinga, the great linga, because what they say is Shiva worshipped himself. That's like, in quantum language, self-referential consciousness. Now, the brain itself is a linga, and inside we can associate the structure of medial lemniscus, which when we view in a cross section, it just resembles another linga. So when we have a linga within a linga, and that is the linga worshipping itself, the Shiva is linga and Shiva worships itself, then that is Mahalinga. So this is how we derive physiologically the prefix of Maha for the linga at Thiruvidai Mardur. Well, now we will explore the relationship correlation between medial lemniscus and the pyramidal decussation. We know that the medial lemniscus is nothing but the ascending sensory fibers, and the pyramidal decussation is nothing but the motor descending pathways, which respectively crosses in the midline. Regarding the location of medial lemniscus formation, which is sensory, that is, the second order neurons from the grisile and cuneate nuclei travel anteriorly, wrapping around the central gray matter and cross the midline just posterior to the pyramids. This is the point to be noted. Now we know that the pyramids are anterior-most, and that correlates with Chidambaram Nataraja temple, and the medial lemniscus is posterior to the pyramids. That means western to the Chidambaram sacred spot. So this is very clear in the map that we will be seeing in the next slide. There is another surprising correlation of the intracranial pathway of the hypoglossal nerve. We can see in the left lower portion the hypoglossal nerve nuclei and the intracranial traversing of the fibers to emerge from the posteriorly located nuclei of the hypoglossal nerve, and the anterior emergence of all the cranial nerves except trochlear nerve, which emerges in the posterior part of the brainstem. Now we see that the posterior aspect of the brainstem, where the hypoglossal nuclei are situated, correlates precisely with the western aspect of the geography of Bharat, and the mythology of Kollur Mookaംಬಿகா clearly correlates with that of the function of hypoglossal nerve, which is to aid in the final delivery of speech. In the Kollur Mookaംಬಿகா mythology, we have an asura who was dumbed before and later given the grace of having his speech restored. And this restoration of the speech can be clearly associated with the function of hypoglossal nerve, because we know that hypoglossal nerve supplies all the intrinsic and extrinsic muscles of the tongue except the palatoglossal. So the surprising fact that we have is there is a very unique presence of Mookaംಬಿகಾ idol, or there is a sacred space within the Mahalinga Swami temple, which is, we know, in the eastern side of the South India, which directly correlates with the anterior brain stem, because we know that the nerves, though there is the nerves of the hypoglossal nuclei, pass anteriorly to emerge from the anterior surface of the brainstem. So this correlation is absolutely divine, and we can see how meaningful. And we also should know that there is no other Mookaംಬಿகಾ temple anywhere else in Bharat except one correlating with the lower nuclei, as we see one temple in Kerala, which is again clearly in the western side. That is, Kerala is in the western side. Coastal area, we have Mookaംಬಿகಾ temple almost in the bottom of Kerala, which can coincide or superimpose with the lower nuclei of the hypoglossal nerve. Well, having seen all the intense correlations in different levels, let's go to basics of how the name Patanjali emerged. Well, there is a famous mudra done with hands known as Anjali Mudra, and Anjali Mudra is nothing but bringing together of the hands like Namaste, more or less, in front of the heart, in front of the chest. So this is Anjali Mudra done with hands. But if the same thing, if we are imagining to do with the lower limb, then we can term that as the Anjali Mudra done with feet. So feet in Sanskrit or Tamil is pada. So pada, using pada, we do the Anjali Mudra, that is joining of them. Then that comes as Patanjali or Patanjali. And this is what happens down in the lower medulla when the pyramidal tracts cross each other. So this could be the scientific or the simple way that the etymology of Patanjali can be explained. So in multiple levels, we are finding that the decussation of the pyramidal tracts is indicated in mythologically in different terms. but we have a solid correlation at multiple levels to confirm our hypothesis. Also, you could see that the exact birthplace of Patanjali Maharshi is not revealed, and his life is largely mired in myth. However, what we see is that the traditional accounts believe that he was an avatar of Adishesha, the divine serpent, who came down to earth from the northern hemisphere, and that also the derivative coming down is another term associated with Patan. So that could be also the source of his first half of the name. And then there is an interesting observation that the place where he comes down from is Ilavrata Varsha in the Sanskrit terminology. And there is also a possibility of Gonda, which is a place in Uttar Pradesh. And also some texts say that he is born of Gonika, the mother is Gonika. Now when we search the actual place, we were surprised to find some Sanskrit terms in the northern hemisphere. Ilavrata Varsha could be a huge place, but the definitions vary in many of the mythological texts. What we found was an interesting location in Scotland where there is a town called Ila, the exact words. I want to note that many of the terms mentioned in Skanda Purana are available in the northern hemisphere word for word. I'm not going deeper into this subject, but it was absolutely amazing to know that the Puranas have not just referred only Indian geographical sites, but it includes so many of places till date. It is being known by the same name that the Puranas mention. Well, unlike the endless Puranas, which we always hear elders telling your stories like the Puranas which are unending, but fortunately we will be concluding this with a brief summary saying that the neuroscientific lens on Anandha Thandava provides a fresh bridge between ancient symbolic wisdom anchored in Maharishi's Vedic science, quantum physics, and modern understandings of the nervous system. By suggesting that Nataraja's form, the Panchabhuta sacred geography, the left limb crossing of Earth into Akasha, which is considered in the right side, and related archetypes may encode deeper insights into brainstem function, pyramidal crossing, autonomic rhythms, monoaminergic modulations, and blissful integration. This model invites deeper inquiry. From a critical angle, it may at best be considered for now as interpretive and preliminary. Well, it underscores the possibility that ancient Indian traditions preserved sophisticated observations about human neurophysiology and consciousness. Insights that remain profoundly relevant for doctors like us who are always inquisitive and explorative, and thus helping the integrative physiology of mind, body, and global harmony.
Yes, continue.
Pleasure to be here with you all. Is it okay?
Yes, sir.
Is it fine?
Yes, sir. Yes, sir.
It's a great pleasure to be talking to you all. I'm sorry I was not able to make it because of the war situation. And am I audible, sir? It's okay?
Sir, am I audible, sir? Sir,
Am I
no, sir. Really sorry, sir. We are running a technical glitch, sir. We are unable to hear your voice. Sir, sorry for the inconvenience.
okay? Can you? No, it's okay. I can call you in the phone.
Okay, sir.
We can.
No, sir, shall I share the doubts through WhatsApp, sir, with you, sir?
Yeah.
Sir, இப்போ கேக்குது.
Yeah.
All right.
Is it audible now?
Yes, sir.
Is
Yes,
it
sir.
okay?
Sir, you're audible
Okay.
now, sir. I think you got to move a little bit
Okay,
closer
very
to the
good, very
mic.
good. Sure.
Thank you, sir.
I'll take my, yeah.
Thank you.
Hello, good evening to all in this assembly, in this elite assembly. Vanakkam, Tamil Vanakkam. Kindly all of you should forgive me for not coming there. I would have enjoyed to be with you all in the divine place of Chidambaram. Yeah, I did my graduation. So, with all my due respects to all my teachers and my seniors, particularly Dr. Sudha ma'am and Sivagangai ma'am, and many of them, I want to convey the fact that a major discovery has taken place, and you would have seen that this is a great discovery, and I would love to answer any queries that you may have, whatever complex or simple, please let me know. Or I can.
If anyone has any questions, you are welcome to ask, sir.
In general, anything like, suppose. Okay. Okay, I will summarize bit. If you don't have questions, I can just. Sudha ma'am, please. Okay. Sure. I'll be so happy to accept your invitation, and we'll have a full session, because what has been revealed to us is something very, very out of the world, and it's this will be the first physiologist will be the first persons who can understand this so well, because the correlation is very simple, and we as Indians have a great responsibility, and as physiologists we have greater responsibility to bring in peace to the world. And as such, we are running through very critical times, and this is all because of lack of coherence, and the coherence can be created by meditation. So people like Indian people, especially Indian brain is suited for meditation. So all the intellectual activities apart, we really need to transcend every day so that not alone for our health, but for the world peace, our temples are most important place. So with that, I would love to get in touch with any of you who have a doubt or to take this forward, and we can collaborate. Thank you to all of the people in Chinnabaram, and we will be in close touch. Thank you so much for this opportunity. Is it okay?
Yes, sir.
No. Thank you so much.
Thank you, sir. We are ending the call right now.
Okay, thank you.
Thank you, sir, for the talk. For felicitation, I would like to call upon Dr. Mani Sundaram, sir. Okay, valedictory speech. For the wrap up, I would like to call upon our Head of Department Physiology, Dr. M. Sudha ma'am, for the valedictory speech.
So before valedictory function, just I want to tell few things about Dr. Satish Vikram. He belonged to third batch of MD Physiology here. We have started a group, alumni group. So first I posted the invitation Anandha Thandava in alumni group. So immediately he responded that I will give a talk on Anandha Thandava, I will book the tickets. But unfortunately he is in Saudi Arabia, so he cannot come here. But he was very much interested to deliver a speech. So only we requested him to send a video presentation. So he sent the video presentation and he wanted to see the audience only. So only we arranged for a Google Meet. Okay, thank you. Now, respected chief guest, distinguished faculty, expert resource persons, my dear colleagues, postgraduate delegates, and my dear students, volunteers. As we stand at the threshold of concluding this enriching Symposium Cum lecture series on Integrated Physiology, I will welcome you all to this valedictory ceremony. We have spent last 2 days delving deep into complexities of human bodily functions, integrating the fundamental principles with clinical reality. This symposium has effectively bridged the gap between theoretical knowledge and practical applications in physiology. The insightful deliberations on genetics, growth physiology, physiology of aging, reasoning out in cardiovascular respiratory physiology, energy metabolism, diet and nutrition, hemodynamics, biopotentials, they have sharpened our diagnostic skills, allowing us to see patients not just as cases but as integrating systems. We have moved beyond mere routine learning to understand why behind physiological mechanisms, which is a hallmark of modern postgraduate medical education. Our deepest gratitude to the esteemed faculty and resource person whose expertise and interactive sessions provided valuable mentorship. These lectures have highlighted an integrated approach to physiology, and it is a key to manage complex pathologies and enhancing patients' care. We thank the organizers for creating this vital scientific platform that has empowered us to advance the cause of research and training in physiology. A special thanks to all participants for their active involvement passionate discussions and for sharing their unique perspectives which made this series so successful. As we conclude this lecture series, let us carry forward the spirit of inquiry and commitment to lifelong learning in our respective fields. A special word of appreciation goes to our organizing secretary, Dr. Manisundaram, whose untiring efforts, meticulous planning, unwavering commitment transformed this vision into a successful academic reality. I extend my heartfelt gratitude for steering this ship with such expertise and passion. Let us give a big round of applause to Dr. Manisundaram for creating a memorable symposium that will inspire our academic endeavors long after this session ends. As a token of love, we, the Department of Physiology, wants to honor him with a shawl and memento. Prem. வாங்க. சீக்கிரம் வாங்க, டைம் ஆகுது. மொமெண்டோ. Hearty congratulations and thanks to the entire organizing committee, volunteers first MBBS students, supporting staffs of Department of Physiology, Mr. Velraj, Mr. Kumar, Mr. Pandiraj, Babu, Hamsa, Dean Office, Mr. Ilayaraja, ground floor lecture hall attenders, Mr. Kannan, Mr. Naveen, and team of audio visual aids, Mr. Saravanan and team, electrical team, Prabhakar and team, decorators for a truly memorable and learning experience. LED projectors. Now, and second word of appreciation goes to Dr. Prem, who is behind the screen. So I welcome Prem. So வெளி வேலையெல்லாம் மணிசுந்தரம் சார் பார்த்தாருன்னா அதர் சயின்டிஃபிக் மற்ற எல்லா கமிட்டி மற்ற இந்த பிடிஎஃப்லாம் இது பண்ணுறது ஃபார்மேட் பண்ணுறது பிபிடி பண்ணுறது மற்ற எல்லா வேலையும் பார்த்தது தான் பிரேம். ஸோ வெரி ப்ரொஃப்யூஸ் தேங்க்ஸ் டு பிரேம். ஷால்லாம் வேணாம், மொமெண்டோ. ஷால் ஷால். I also thank our assistants, Dr. Shanta and Dr. Amudamari, to come on to stage. And Dr. Sivayangalashmi ma'am. Sivayangalashmi ma'am na அவங்க வந்து லாயர் படிச்சிருக்கணும், அதான் கரெக்டு. நாங்கள் எல்லாம் பண்ணி முடிச்சுட்டு ரிஹர்சல் முடிச்சுட்டு எல்லாம் பண்ணுவோம், கரெக்டாக ஒரு தப்பு கண்டுபிடிப்பாங்க. ஸோ அதுக்காகவே அவங்கள வச்சுப்போம். அதுக்கு செகண்ட் வந்து அவங்களோட சப்பார்டினேட் வந்து டாக்டர் அமுதா. எல்லா வேலையும் முடிச்சுட்டு சரி நம்ம எல்லாம் கரெக்டாக சக்ஸஸ்ஃபுல்லாக பண்ணிட்டோம் அப்படின்னா கரெக்டாக வந்து ஒரு பாயிண்ட் சொல்லுவாங்க, இது தப்பு அப்படின்ட்டு. ஸோ thank you, Dr. Sivangai. She is like my sister. So I will be missing her. That is after 2 months, I think. Sivangai, நீங்க தான் பண்ணணும். அம்மா கொடுப்பா. சாந்தா ஸோ அமுதமொழிக்கு வந்து நாங்கள் என்ன தான் ரிஹர்சல் பார்த்தாலும் அங்கே சிவகங்கை இல்லைன்னா அவங்களுக்கு பிடிக்காது. சிவகங்கை மேம் எங்கே, சிவகங்கை மேம் எங்கே, அவங்க தான் ஃபஸ்ட்டு அவங்களுக்கு. சாந்தகுமாரி வந்து எனக்கு செல்ல பிள்ளையாட்டம். எதாக இருந்தாலும் சாந்தா சாந்தா அப்படின்னு கூப்பிட்டு என்ன இருந்தாலும் சொல்லிவிடுவேன். Okay. Last but not the least, my dear PGs. So PGs 9 பேர் இருக்காங்க. They have done a wonderful job. ஸோ நான் ஆக்சுவலாக ராமநாதபுரம் போன வருஷம் வந்து முடிச்சுட்டு வந்தோடனே நம்ம வந்து இதை பண்ணணும்னு சொல்லிக்கிட்டே இருந்தோம். பட் லாஸ்ட்டு 3 months ஒரே டென்ஷன், என்ன பண்ணுறதுனே தெரியல. ஒரு புக்கு ஒன்று வச்சுக்கிட்டு டெய்லி எழுதிட்டே இருப்போம், என்ன எழுதணும்னு தெரியல. அட்ரஸ் கலெக்ட் பண்ணுறது, அதுக்கப்புறம் ஒருத்தவங்களுக்கு இன்விடேஷன் அனுப்பணும், வேறு என்ன பண்ணுறதுன்னு யோசிச்சு பட் the PGs have done a wonderful job. Next, our volunteers, my dear students, MBBS students, 55 members. So I really appreciate the work. I think we have become successfully conduct பண்ணிட்டோம்னு நினைக்கிறேன் because of their efforts only. So அதில் accommodation committee, food committee, வேறு என்ன கமிட்டிப்பா, reception committee, scientific committee, registration committee, then பரதநாட்டியா, அது ரொம்ப சூப்பர். Welcoming dance by Sriniti and Nevita. That was very much wonderful. That was appreciated by all also. And food committee, accommodation, reception committee, Rangoli team, they also performed well. So I profusely thank all of you. The success is yours. It is because of yours. Thank you one and all. Ma ella vandu or photo. Organizing team fulla. All of you come forward. Organizing team, come forward all of you. Volunteers. என்னது ஆனந்த், அவர் அலுமினி வாங்க. ஸோ ஆனந்த தாண்டவா அனௌன்ஸ் பண்ணோன்னே ஃபஸ்ட்டு பிஜி ரெஜிஸ்டர் பண்ணதே எங்கள் ஆனந்த் தான். அவர்
See, we have to thank our respected HOD ma'am for everything actually. Because we have to give a big round of applause only for our HOD ma'am. Actually, அவங்க மேடம் வந்து இது வரைக்கும் எங்களை பார்த்து ஒரு சத்தம் கூட போட்டது கிடையாது. வேலை செய்யலனாலும் அவங்க சத்தம் போட மாட்டாங்க, வேலை செஞ்சால் ரொம்ப அப்ரிஷியேட் பண்ணுவாங்க. மேடம் பெர்மிஷன் கொடுங்க மேடம், பீக் ஆஃப் த மொமெண்ட்டில் பெர்மிஷன் we will ask, but she will just look at us. சரி போ, that's all she will tell.
She actually dreams in her the vision of Anandha Thandava comes in his dreams every day.
சுதாவுடைய நீண்ட நாள் கனவு நிறைவேறி இருக்கு. அது வந்து எங்கள் எல்லாருக்கும் ரொம்ப சந்தோஷம். we are also a part of it என்னும்போது we are also proud about that.
இந்த நேம் ஆனந்த தாண்டவோ நாங்கள் வேறு நேம்ஸ்லாம் சொன்னோம், பட் the name was suggested by our HOD madam only. அதுதான் ரொம்ப சக்ஸஸ். she is very soft, polite and very lovable also. இல்லை மேம் சொல்லி தான் ஆகணும். I was very starting, we came from government, no, we were very much how will the people of this college be, but in spite I have to definitely tell she is one of my best HOD actually. That's really நான் மற்ற HODs பற்றி பேசும்போது அப்போ கூட நீ என்னை பற்றி சொல்ல மாட்டேல்ல, she will ask actually எங்கள் HOD மேடம் யாருமா பற்றி பேசுகிற, but now I'm really very 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 proud to tell that she is my HOD actually. Thank you so much ma'am. So ma'am, so our professor madam will felicitate our dear HOD madam. So please, I wanted to really appreciate.
ரேகா ஒரு ஃபோட்டோ வந்து எல்லாரும் ஒரு ஃபோட்டோ எடுக்கணும். மேடம் நீங்கள் வாங்க, ஒரு ஃபோட்டோ எங்களோட. Participants also can join us for our photo. If you And I thank comparing committee which I have left for wonderful comparing and who is responsible for the successful running of the program. Thank you very much. Thanks a lot. The comparing team, madam, அவங்களுக்கு வந்து பயோகெமிஸ்ட்ரி எக்ஸாம் இருந்துச்சு, எங்கள் எக்ஸாம் இருந்துச்சு. ஸோ பயோகெமிஸ்ட்ரி எக்ஸாம் வந்து 17th 16th ப்ரீபோன் பண்ணி வச்சோம். ஆனால் அவங்கள விட்றதே இல்லை. டெய்லி காலையில் வந்து திருப்பி சொல்லுன்னு என்னமோ ரிவிஷன் கிளாஸ் அப்போ இதை தான் ஒப்பிச்சிட்டு இருந்தாங்க அவங்க. எனிவே, தேங்க்யூ வெரி மச். இன் ஸ்பைட் ஆஃப் யுவர் எக்ஸாம்ஸ் அண்ட் ஆல் யூ பிளேட் வெல். தேங்க்யூ வெரி மச். சார், முனியப்பன் சார் வாங்க சார், ஹரிபாபு சார் வாங்க எல்லாரும். I also thank Dr. Muniappan sir for spending his valuable time for 2 days. He is an anatomy professor and HOD retired professor, but very enthusiastic.
I request all the students to stay back. All the volunteers to stay back.